Good evening, everyone. Hope I'm audible. Hello, hello. Am I audible, guys? Okay, let me just check the audio, video, everything first, then we'll start the class. Right? So let me confirm. Okay, perfect, perfect. So, good evening, everyone. So, due to last minute some technical issues, we had to do this session on YouTube itself. So, we are sorry for the inconveniences. So, whoever is there, can you just let me know if audio, video, everything is clear in the chat box, please, so that we can start the session. Let me just see this thing. Am I audible? So, good evening, everyone. So, welcome to today's session of Pharmacology Rapid Revision, which is about 4 to 5 hours, I think. So, though it might be in a short period of time, so the target and plan of the today's session I'll explain. Let me tell you the plan and this thing. So the plan is very simple, Bacho. What you are supposed to do is very interesting thing. So what we are supposed to do, already you would have read pharmacology. Now it is not the time you are going to tell me, sir, I'm starting pharmacology now. Just let me set my phone up for this thing. So just let me inform our team as well. So just one second. If that is done, I'll continue. So guys, please look at the chat box, everyone. So we are going to start our YouTube live in few seconds now. So actually we are live anyways. So what I'm trying to tell you is we are starting this session to make sure that I'm going to touch every important aspect of the pharmacology. So it is not going to be like I'll be teaching the whole pharmacology. It is not nothing going to be like that. I'm just going to touch the important aspects of each of the part. That is the one thing we are going to do. The second thing, we try to dissect the important MCQs which can be potentially asked. Okay, so last two to 3 years, the FMG paper, especially with respect to pharmacology, is becoming is in such a way that there is no big difference actually. Okay, so what do I mean by there is no big difference between other exams like NEET or maybe INI-CET? Okay, so that is the point I'm trying to tell you. Okay, so the point you need to remember is, so you are supposed to make sure your pharmacology is done according to the recently asked question pattern. Okay, so those who have done classes with me, you would have read from me, so I would have told a lot and lot of information to you people specifically regarding how the newer questions are being asked. So that is there. So anyways, now what we are going to do is, so we'll touch the important aspects. I'm not going to teach the whole thing, any system. I'll be very honest. I'll be touching only those important things which are being asked. Okay, because we have 4 hours, we need to go through that, and later you're going to solve a set of MCQs probably. And the next important thing, what you're supposed to do from now on, already our schedules are out, right? So which class is going to come when? So you can find it on Meduhub page as well. So because of that, you can do one thing. You can plan out your preparation according to that, and you can just keep on preparing the same subject. For example, today is pharmacology. You could have prepared pharmacology at least 2 to 3 days before, so that now it will be even more easier. Okay, so that is the idea behind this program, and we are doing it in such a short time because we want to give one more important thing, not just giving the information, but also we want to give you the confidence of the subject, because once you have done one complete subject, you'll feel like, okay, I have done something, right? So that confidence will boost you to study better. All right, so let's start off with the general pharmacology, right? So whenever we are speaking of general pharmacology, so in the general pharmacology, what are the important aspects they might ask you? I'll tell you. So the important things can be asked is from the routes of administration. From the easiest questions, we will start off. Okay. So what is that? Route of drug administration. Route of drug administration. So when you are speaking of the routes of drug administration, we have lots of routes of administration. So such as oral is there, rectal is there. So basically we have enteral and parenteral, enteral and parenteral. So whenever we are speaking of enteral and para-enteral, there are most important aspects is enteral. Enteral is any route where intestine is required for the absorption of a drug. Basically, drug absorption occurs through the intestine, small intestine. That's why we are calling it as enteral. Okay, enteral means through the intestine. So we have oral and perrectal. Perrectal. So oral and perrectal, there are only two questions which can be asked possibly. They are going to the easiest question for you people. So what is the disadvantage and advantage? Disadvantage and the advantage. Okay, so what is the advantage and what is the disadvantage? So you can let me know in the comments as well. Disadvantage is that they are the most important disadvantage because of this is one is your first pass metabolism. What is that? First pass metabolism. For those of you who don't know what is first pass metabolism is the metabolism of the drug. Means the drug will break down before even reaching the circulation. Means when you swallow a drug, it will go to the intestine. From the intestine, drug has to get absorbed. After the absorption of the drug will go to the liver. From the intestine, it will go to the liver from the portal circulation. In the liver, drug might break down. Right, if the drug breakdown occur even before reaching the main circulation, we'll call it as a first pass metabolism. So disadvantage is first pass metabolism because drug will get metabolized even before reaching the circulation. Okay, okay, so this is main important aspect. Okay, so what is the disadvantage? The first pass metabolism, whether high or low, first pass metabolism will be, everybody tell me high or low. The first pass metabolism is going to be high, so that is a disadvantage for the enteral and enteral route of administration. Advantage is easy to administer, of course. Okay, and one more is we can prolong the duration of action. Can prolong the duration of action. Okay, so why? Because we can make the drug, manufacture the drug in such a way, it will absorb slowly. As it absorbs slowly and slowly, the drug absorption will occur slowly, so the drug will remain in the body for a longer period of time, so we can prolong the duration of action. So this is the two important points to be remembered. Para-enteral, they'll ask you only two important possibility of MCQs. So para-enteral, what is the route of the administration which has a highest bioavailability? So highest bioavailability. Okay. So highest bioavailability. When we are speaking of highest bioavailability, so the highest bioavailability is always there for which route? Everybody tell me. Highest bioavailability is always there for IV route. Highest bioavailability is always there for IV route because the drug is directly entering the circulation. Okay. So this is one important. Then in the para-enteral, you have your sublingual also. You have your sublingual. So sublingual, what can be the possibility of the question which can be asked? So as a MCQ possible, it can be asked is if there is a sublingual drug route is been, the sublingual drug has been given. So if the drug is given sublingually, where does the drug go? So drug directly below the tongue, from below the tongue, it will enter into the neck vein. So it will get absorbed into neck veins, so into neck veins means directly it is reaching the systemic circulation. So that is the advantage of sublingual. So sublingual also has a faster onset of action. That's why sublingual falls under parenteral. So parenteral में sublingual भी आ जाता है. Okay, sublingual also falls under the parenteral category. Okay, so this is a point which you need to remember. Okay, so please listen to me very carefully. I'll give you the question. See, since we started with the very basics, यहाँ पे मतलब मजा नहीं आएगा. Okay, so when power play is there, तब 6 मार के मजा आएगा. ठीक है? So थोड़ा अभी शुरुआत किए, थोड़ी देर time लगेगा. Okay, I'll ask you questions also. Definitely. Okay. All right, guys. Let's continue to the next important. So one of the next topics which you need to go through is pharmacokinetics. Pharmacokinetics. Okay, so pharmacokinetics, say what are the possibilities they can, like, what are the ways where we get confused. Let's touch all of them. So pharmacokinetics is the effect of human body on the drug. Means what your body will do to the drug, that is what is going to be asked. Okay, so that is what is the definition of pharmacokinetics. So if we are looking at pharmacokinetics, the first thing, as soon as you swallow a tablet, let's imagine you swallowed a tablet, drug went into the GIT. So from the GIT, what your body will do? The body will absorb the drug. So first thing we are going to look at is absorption. Okay, so absorption. So when we are speaking of the absorption, so there are some conditions where the drug absorption can become faster, right? There are some conditions where drug absorption becomes slower. So what are the factors which increase the absorption? Okay, factors which increase the absorption. Increase the absorption. Okay, so basically factor which increase the absorption means what are the scenarios where absorption will become faster. So the first and most important is what is a dosage form you are giving. Dosage form of the drug. So when we are speaking of the dosage form, which type of drug dosage forms means whether solid form or a liquid form or a gaseous form, which one will get absorbed better. Okay, always remember among the liquid and solid, liquid dosage form has more absorption than the solid dosage form, which clearly says any solution of the drug will have a better absorption as compared to that of a tablet or a powder form of the drug. समझ में आ गया सबको? ठीक है, that is a dosage form का कहानी. All right. Okay, then the next important thing which you are going to look is, so the most important aspect that you are going to look is gastric emptying. Gastric emptying. Okay, so gastric emptying. So remember, absorption, maximum absorption occurs in which part of the intestine? If orally, if you give the drug orally, if orally given the drug, so the maximum absorption occurs in which part? Everybody tell me. Maximum absorption of any drug. Maximum absorption of any drug. Maximum absorption of any drug. Yes, tell me. Maximum absorption of any drug, where it will occur. Always remember. So remember, it is in the small intestine. Okay, so that is in the small intestine. So that is in the small intestine. Sir, why small intestine? So the small intestine is the correct answer because irrespective of the nature of the drug, or maybe acidic or basic, at the end point, the summary is very simple. Where the drug will absorb highest is in the small intestine because of its highest surface area. The surface area is a key point. Okay, all right. So once we understood about this, then the next important point is nature of the drug. A nature of the drug के बारे में is very important. Nature of the drug. Okay, and media. Okay, this is a very important concept to be medium. Okay, or media. Okay, so this is a very important concept. So drugs can be as weak acids हो सकते हैं, right? Drugs can be weak bases. Drug can be weak acid or a weak base. Drug can be weak acid or a weak base. So weak acid कैसा react करता है? How does it react? Weak base, how does it react? In each media means if there is a drug. Drug is what? Let's imagine acid. Drug is a acid. Now acid went into, let's imagine, stomach. Where did it go, bacho? It went into the stomach. So stomach surrounding pH is also acidic because of its environment, right? So now acidic drug is present in the acidic surroundings. How will it act? The same acid drug, if it comes into the duodenum pH is basic. How it will act if the drug reaches into where? Into the duodenum, if the acid reaches. Or if, for example, basic drug is there, basic drug went into stomach. So basic drug, if it is gone into stomach, how will it interact? That's what is the concept. Okay, all right. So in which what you need to remember, so what you need to understand is very simple thing. So the most important aspect to be remembered here, okay, what is that? That is the acidic drug. Okay, so first let's look at an acidic drug. Okay, then there is a basic drug, then there is a basic drug. All right, so and also acidic environment, acidic pH, surrounding is acidic pH, and one more is there, alkaline pH. Okay, so remember, simple as that. If same pH is there, the condition will become stable. Means, what do I mean by this? So if the acidic drug present in a acidic pH, drug is unionized. If the drug is unionized, it will have a better absorption, increase the absorption. So if the drug is unionized, absorption will be better. Understood, everybody? Now you people should tell me if it is in an opposite pH. So acidic pH is a surrounding environment and drug is a basic drug. Then what is the difference? So basic drug in an acidic media, it will become what is that? Ionized. What it will become? Ionized. If it becomes ionized, automatically the drug absorption will be reduced. Reduce the absorption. Okay. So the next important point to be remembered, exactly acidic drug, you people will tell me acidic drug in a alkaline pH. But acidic drug in alkaline pH, what will occur? will occur? Exactly, acidic drug and alkaline pH, exact opposite thing. So the drug becomes ionized. Ionized हो जाएगा तो it decrease the absorption. Okay. The next point you need to remember, alkaline drug in a basic drug in a basic pH. So the drug is unionized. If it is unionized, automatically it will have a better absorption. So this is the story of your, what is that? The pH and the drug. Okay. The same thing here only. Let's read the clinical correlation. Clinical correlation. So there is a very commonly asked question. Maybe due to some lag, if at all, if there is few seconds lag is there. So if at all that is coming up, but you don't keep quiet, keep answering the questions which I'm going to ask. Okay, that you need to do it. Okay, so clinical correlation. So if there is, for example, acidic drug overdose. What are the acidic drug overdoses we are going to get? And this is a previously asked question. Mazak mein mat lena isko. Okay, so acidic drug overdose. What will happen? Let's see what are the drugs we have. Let's look at the examples. Okay, the examples of the acidic drugs are your aspirin. Okay, aspirin is a acetyl salicylic acid, and also your barbiturates. So we have aspirin and barbiturates which are being present as a acidic drugs. Okay, so these are the common acidic drug overdoses, but these two does not have an antidote. That is the main point. Other drugs which has an antidote, might have a different way of antidote using and treating can be possible. But here, for all the acidic drug overdoses, the treatment protocol will go almost little bit similar. What will be there? The treatment will be forced alkaline diuresis. Okay, so basically, so alkaline diuresis by using, what is that? By sodium bicarbonate, soda bicarbonate. Okay, and diuresis will be done by loop diuretics. Diuresis will be done by which diuretics? Loop diuretics. Okay, now when we are speaking of forced alkaline diuresis, so basically why we are doing alkaline urine? Okay, normally urine pH is acidic. Okay, now our drug is also what? Our overdose is also what? Acidic, right? Overdose is also acidic. So acidic drug in an acidic environment. So from the kidney, drug has to go out of the body. What is the target? To flush the drug out of the body. But if we are unable to flush the drug out of the body, why we are unable to flush? Because even though we are giving the diuretic, drug is not going out, because normally urine pH is also acidic. Our overdose is also acid. So that time what will be there? Reabsorption can occur. Reabsorption is possible, means the drug will come back into the blood vessel. Okay, if the drug come back into the blood vessel, then there is no point of giving the diuretic, because the drug is being reabsorbed. So we want to clear the drug, we want to remove the drug. So to overcome this, what we are going to do? To overcome this, exactly we are doing, we are alkalizing the urine. Okay, so this is the concept behind it, and they are going to ask you a simple question during the forced alkaline diuresis. Why we are doing the alkalization of the urine? To overcome the reabsorption from where? Renal tubule. So to overcome this, we using alkalizing the urine. So basically, alkalizing the urine will do what? Prevent the reabsorption of the drug. Okay, and exactly the wordings are going to there, they can mention is prevent the tubular reabsorption is going to be the better terminology which you can look at. Okay, so prevent the tubular reabsorption of the drug, we are doing the alkalization of the urine, and absorption concept is also here only. Okay, now absorption depends upon gastric emptying. Okay, depends upon the drug, depends upon the solubility of the drug. Lipid soluble drugs will have a more absorption nature. Okay, solubility, let's look at the solubility of the drug. Solubility, so lipid soluble will have a better absorption because than the water soluble drugs. Okay, so this is the story of your, what is that? This is the story of your, yes, of course, the story of your absorption. Okay, then let's go to the next one, bioavailability. Now bioavailability in last 2 years, there was not many question, but there is a possibility highest bioavailability, lowest bioavailability. They might give you a graph about the bioavailability and formula for the bioavailability. These are the possible things they can ask you. Okay. So basically highest, it is represented by a letter F. Okay. Highest bioavailability is for which one? Highest bioavailability is for the IV route. Highest bioavailability is for the IV route. So bioavailability F is inversely proportional to first pass metabolism. Simple as that. Okay. First pass metabolism. What do I mean by this? Very simple to understand. Listen to me very carefully. F means bioavailability. Bioavailability is inversely proportional to what? Inversely, very good, correct answer. I is a correct answer, of course. So F is inversely proportional to first pass metabolism. How and why? Very simple. If somebody takes the drug orally, if more drug break down before reaching the circulation, more drug in the circulation, the drug amount will be less. So what is the definition of bioavailability? The definition of bioavailability is very simple, bacho. The amount of drug which is available in unchanged form. Amount of drug reaching the circulation in unchanged form. In the unchanged form. That is what is called as what? That is what is called as your bioavailabilities. Okay. So bioavailability is inversely proportional. So let me take you through the graphs of the bioavailability. So which one has almost 100% bioavailability? 100% bioavailability is for the, yes, of course, 100% bioavailability is for your, that is IV. Okay, almost 100. Okay. So now, in this, we are going to look at the plasma concentration of the drug in the y-axis. On the x-axis, we are looking at the time. So, at the time when I'm giving the drug, as soon as I give the drug, immediately there is a large quantity of drug went into the vein. So, basically, large quantity of drug is available in the vein. So, if it is available in the vein, as soon as at the time of administration itself, maximum plasma concentration, as time passes, the drug will start to break down. So as the drug time passes, drug will get metabolized or it will get distributed into the tissue. Drug will get metabolized and drug can get distributed into the tissue. It has a two phases. Okay. So initial phase, okay, alpha, later phase, beta. Initial phase, alpha represents the distribution, beta represents the elimination and clearance. Okay, but as such, remember the shape of the curve at least. Okay, so whatever the area which is present under this curve, whatever the geometrical area which is present, we will call it as a area under the curve. Okay, so this is your for the IV route. Okay, then the next one we can look for is next common route is oral route. So we are looking at only for the oral route. Okay, so we are looking for oral. So on the y-axis again we are going to look at the plasma concentration. On the x-axis we are going to take out the time. Okay, so on the oral route, at the time you swallow the drug amount will be 0 in the body. So after you swallow, after 1 hour, little bit drug absorbed. After 2 hours, more absorption. After 3 hours, more absorption, right? It will reach a maximum level of concentration. Followed by that, as the time passes, absorption is finished, the drug will start to get metabolized, right? So the plasma concentration come back to the 0. So this will be the area under the curve for your, yes, oral route. So for the oral route, whenever we are speaking, so here we are going to get one terminology. So the plasma concentration, the maximum plasma concentration, whatever we are achieving is called as Tmax. Okay. The maximum time it is taking to reach that concentration, we'll call it as a Tmax. That's it. Okay. So there is one formula for the bioavailability. The formula for bioavailability, F, that is bioavailability is equal to area under the curve for the oral route divided by area under the curve for the, yes, area under the curve for the IV route multiplied by 100 will be the formula. Okay, So in the main classes, I would even have explained why exactly this is the formula, but we don't have that much time here to do that now. So just remember the formula at least. Area under the curve for the oral route divided by area under the curve for the IV route. Shows you what is that? Shows you the bioavailability of a drug. Okay. So let's go to the next one. Next one. Okay. So the next important concept is okay, absorption is done. Okay. So the next one is your distribution. So distribution, almost every factor which affects the most importantly what bioavailability will affect the distribution. Every factor which affect the bioavailability means bioavailability depends upon absorption. So if absorption is more, distribution of the drug will also be more. So basically, what is distribution during bioavailability? What did we say, sir? During the bioavailability, the amount of drug reaching the circulation in an unchanged form. So from the circulation means from the blood, now the chemical has to go into the tissue. So we'll call it as a distribution. Okay. So in the distribution, so what exactly we need to look for? Okay. So in the distribution, so one of the most important concept which always you need to remember, see, if the drug is lipid soluble, automatically it will cross the membranes more and it will reach the tissues more. That you can come to the conclusion. But most important concept which everyone will miss out is the plasma protein binding. Plasma protein binding means what? It is the blood vessel. In the blood vessel, we have a plasma protein. Let's imagine albumin. If the drug is binding with the albumin, so if some drug D is there, so drug is strongly bound with the albumin. If the drug is strongly bound with the albumin, what will happen? So plasma protein bound, if it is high, plasma protein binding, if it is high, automatically the drug will remain in the circulation for a longer period of time. So from the albumin, it will dissociate slowly. If it will dissociate slowly, automatically that is going to do what? Increase the duration of action. Okay, so they increase what? Duration of action. How they will increase the dissociate slowly? Why they will dissociate slowly? They will dissociate slowly because yes, because they have a high ability to bind. Okay, so if dissociate slowly, it will increase the duration. It work as a reservoir, work as a drug reservoir. Okay, that is a one point you need to mandatorily need to remember. What if the drug is highly plasma protein bound, automatically what will happen? It will dissociate slowly. Because of this plasma protein binding, they can show displacement reaction. Which reaction? Displacement reaction. Basically, one drug will come and send the other drug from the albumin. For example, let's imagine albumin. Albumin is binding with what? Albumin is strongly associated and binding with, of course, your bilirubin. Okay. But if sulfonamide comes, so albumin is binding with what? Albumin was binding with, let's imagine, bilirubin. Okay. But now what will happen? Sulfonamide will come. Now sulfonamide and albumin will fall in love. So what will happen? Albumin will go and bind with what is that? His favorite version was sulfonamide. Okay. Automatically now bilirubin will become free. It will become what happened to me? So bilirubin got displaced. Okay. If bilirubin got displaced, free bilirubin in the blood vessel will be higher. Free bilirubin in the blood vessel will be. If free bilirubin in the blood vessel is higher, so now what will happen? Bilirubin, if it is more, it will lead to jaundice, right? So instead of that, if there was other drug will be, instead of bilirubin, there was some drug. Now drug will do what? Drug will become freely higher in the blood vessel. So if the drug becomes freely higher in the blood vessel, that will lead to what? Toxicity. So displacement reactions can cause toxicity. So from, if they can cause a toxicity, they will ask you the example and they'll give you clinical scenarios. So especially they can give you two important clinical scenarios. One is bilirubin ka scenario and one more possibility is your non-steroidal anti-inflammatory drugs displacing your warfarin. Okay, so NSAIDs. NSAIDs displace the warfarin. So automatically warfarin. So they will lead to what is that? Warfarin toxicity, leading to toxicity of warfarin. This is a high possibility. So they will give you a question. If they give you about displacement reaction, the question could be something like this possibly. What can be the question? So listen to me. They can frame it something like this. Okay. What they'll tell you, a 55-year-old male who is a known case of atrial fibrillation was taking the treatment for atrial fibrillation with the help of calcium channel blockers and also warfarin as an anticoagulant. So recently he took a over-the-counter pain medication. After taking the medication, patient started to develop increase of INR, or maybe high bleeding tendencies were found. This could be due to what? This could be due to displacement reaction. Because of what? NSAID displaced the warfarin. Okay, that is a point. Okay, then your sulfonamides, okay, displace bilirubin, okay. So these are one of the possibly potentially asked displacement reactions. Okay, so sulfonamides displace bilirubin. If the sulfonamide displace the bilirubin, they lead to jaundice. Okay, so this is a story of your displacement reaction. All right, let's go to the next one. So once we are done with the distribution, and the next point you need to remember is very easy to remember. So what is that? Yes, of course, that is solubility of the drug matters a lot. Why? Because if there is a lipid soluble drug, it will have a higher amount of what? Higher amount of your distribution, because it will cross the membranes easily, of course. So any lipid soluble drugs can cross the barriers, be it a blood placental barrier, be it a blood CSF barrier, be it a blood testicular barrier, okay, be it blood brain barrier, anywhere. Okay, they can cross very easily. Once we understood about these 2 points, one more important aspect is redistribution. So redistribution occurs with a highly lipid soluble drugs. Come on, can anybody tell me the example, the classic example of a drug which undergoes the redistribution? So redistribution of a drug occurs if there is a highly lipid soluble drug. Occurs with a highly lipid soluble drug. Okay. So if it is a highly lipid soluble drug, redistribution will be seen with one drug which you must remember, that is only thiopental. What is the name of the drug, bacho? Thiopental. Okay. They can ask you this question: which of the following drug shows a higher amount of redistribution? Higher amount of redistribution is done by your thiopental. Which one? Thiopental. Okay. So thiopental is a barbiturate, which is a induction agent. All right. Let's continue to the next concept once we are done with the distribution. Okay, metabolism related, every alternate or every 3-4 exams once there is a possibility of asking this question, especially metabolism of the drug. So all the metabolism of the drug, highest amount, most common site of metabolism, of course all of you know, liver, right? So there are two types of reactions. Okay, phase 1 reactions, okay, and phase 2 reactions. Okay, so what is this phase 1 reaction and what is this phase 2 reaction? Simple, guys. The target of metabolism is to convert a fat soluble drug into water soluble so that it can be eliminated easily. Okay, that's it. Thiopental is the correct answer. So basically what you are supposed to, what is the target, sir? The target is very simple. We want to convert a water soluble drug, lipid soluble drug into water soluble so that it will get eliminated. So for that only we have so many reactions. Okay, so phase 1, all the phase 1 reactions, and also you have a phase 2 reaction. All these phase 1 are called as non-synthetic reaction, means they are not going to create any new metabolite. Okay, new metabolite is always created in your, what is that, phase 2. Okay, phase 2 only, new reaction, phase 2 is the one. Okay, so all the phase 1 reaction are microsomal reaction, occurs in your microsomal of the liver, microsomal enzyme. So which is the microsomal enzyme? We have CYP enzyme, which is the enzyme CYP. Okay, which one? Cytochrome CYP 450. Okay, but not just CYP 450. Actually, there are others also, the cytochrome enzyme. Okay, so most common enzymes CYP 3A4. Okay, this is the most common enzyme which plays a role in the microsomal reactions. Okay, then you have synthetic reaction where waste product is created and that can be eliminated, or maybe toxic metabolite can be formed. One is your acetylation. Again, acetylation related questions have been frequently asked. I don't want you to miss out anything here. Acetylation. Okay, you have your sulfur reaction, or also called as sulfur conjugation. Sulfur conjugation. Okay, you have your glucuronidation. Which one? Glucuronidation. Okay, you have even more other reaction, acetylation. Okay, glucuronidation. So many reactions are there. Here only simple reaction in the phase 1. Only simple reactions can occur. Which are those simple reactions? Of course, your oxidation, reduction. Okay, cyclization, decyclization. This type of reaction fall under which one? Phase 1 reactions. Phase 1 reactions. Okay, phase 2 are which one reactions? Synthetic reaction. Phase 2 are which reaction? Synthetic reactions. Okay, so these are non-microsomal. So the most important aspect which you need to remember is drugs undergoing, what is that? Drugs undergoing acetylation. Okay, drugs undergoing acetylation. Okay, going acetylation. Okay, this is a very important question because a lot of side effect related questions can be asked from here. So be very careful. The drugs which undergo acetylation, all of these drugs usually increase the risk of drug induced SLE. Increase the risk of drug induced SLE. Okay, so they increase the risk of drug induced SLE. Okay, this is one thing. Which are the drugs which undergo? All of you know already. Sulfur drugs. All of you know already. Sulfur drugs. Yes, of course. Then you have your hydralazine. Hydralazine, right? Okay, that is only your mnemonic ship drug. Okay, then your isoniazid. Isoniazid. Okay, then you have your local anesthetic procainamide. What is that? Procainamide. Then you have your dapsone. These are the few common drugs which undergo what is that? Of course, dapsone is one of the few drugs which undergoes what? Acetylation reaction. Acetylation reaction. So these drugs which undergo acetylation reaction always increase the risk of, yes, of course, increase the risk of your drug-induced SLE. Okay. So once we understood about this, we have enzyme inducer and enzyme inhibitor. Enzyme inducer. So remember enzyme inducers are, so basically they increase the activity of one common enzyme CYP 3A4. Okay, so CYP 3A4, one of the common enzyme, they increase. So if CYP 3A4 activity is increased, now imagine drug A is there, drug B is there. Okay, both are metabolized by same CYP only. CYP 3A4. Both of the drugs are metabolized by CYP. This A is going and increasing the activity of CYP3. Now CYP3A4, if activity is increased, it will come and destroy the drug A also, and it will come and destroy the drug B, because this is the same enzyme which is metabolizing both. Because of some drug A which had a increase or inducing property on the 3A4, it caused the metabolism of both A and B. So automatically, if there is an increased activity of CYP3A4, there is an increased metabolism of the drug. If the drug will get metabolized faster, treatment will be successful or a failure? Everybody tell me quickly. Treatment will become successful or a failure? Of course, treatment will be a failure. Treatment will be a failure, leading to what, sir? Yes, treatment failure, leading to treatment failure. Okay, so this is a very important point, because enzyme inducer, so the commonest enzyme inducing property and interaction has been frequently asked. So that drugs includes your griseofulvin. Okay, then you have your, yes, you have your phenytoin. Okay, you have your rifampicin. Okay, so then you have your smokers. All right, then you have your carbamazepine, which is an anti-epileptic drug, and your phenobarbital. Okay, so these are your enzyme inducers. Okay, so once we are speaking of enzyme inducers, so please listen to me very carefully. What is that? Griseofulvin, phenytoin, rifampicin, smoking, carbamazepine, and phenobarbital. These increase the activity, so automatically they'll ask you the drug interaction between these ones and a oral contraceptive pills. Okay, a 27-year-old married female on OCP started treatment of your, of course, pulmonary TB. She became pregnant. She is pregnant. Okay, so which drug is the likely cause? This was a previously asked question. Okay, is the likely cause. Okay, so likely cause is which one? Options. Okay, so they will give you isoniazid. Option B, rifampicin. Option C, okay, ethambutol. Option D, pyrazinamide. Okay, so many times it will confuse you. Okay, so why it will confuse you? Because on the other hand, in the enzyme inhibitor we have isoniazid. I want you to answer this one very clearly. What are the drugs we have? What are the drugs which will cause this side effect? Of course, very good answer. Answer is your rifampicin. This is a very commonly asked question. This is a from the recalls it has been asked, so please remember. Let's go to the next question. So the next topic, okay, enzyme inducer inhibitors are also there. Enzyme inhibitor, I'll just tell verbally. Enzyme inhibitors include your isoniazid, ketoconazole. Okay, enzyme inhibitors are isoniazid, ketoconazole, sodium valproate, cimetidine. Okay, so those are enzyme inhibitor, but these are the most common points which you need to remember. Okay, now once we understood about this, so just let me tell you one thing. We are doing general pharma in this fashion, in detailed fashion, but once we enter into the system, the approach is going to be very different. What are the common diseases, what are the common drugs, and their related information and surrounding important things to remember. That's how we are going to approach. Okay, all right. Okay, now let's continue to the next aspect. What is the next aspect which you need to remember, which you need to understand? Excretion. So excretion, we have two important things to remember. One is your first order kinetics. One more is your zero order kinetics. So first order kinetics and zero order kinetics. So zero order kinetics में क्या होता है? Fixed amount will go out. Fixed amount is lost. Okay. In first order kinetics, what will be there? Fixed fraction, basically fixed percentage will be going out. Okay, so in that, most commonly asked examples for the kinetic. So most common type of order of kinetics is your first order kinetics only. Okay, most of the drugs will undergo which kinetics? First order kinetics only. Okay, zero order kinetics. The classic example is alcohol. Okay, apart from alcohol, okay, there are some other drugs at a higher doses. Okay, at higher doses, what are the drugs which undergoes the zero order kinetics? Let's see. Okay, at higher doses, the drugs will undergo zero order kinetics. This was also old question. Okay, so if you give in a large dose, they will also enter into zero order kinetics. What are the drugs which will enter into zero order kinetics? So one is your warfarin. Okay, you have your aspirin. Okay, you have your tolbutamide. Okay, so you have your tolbutamide, very important drug. At a higher doses, it will enter into zero order kinetics. Okay, actually, to be very frankly speaking, almost all the drugs, if given in a massive doses, can enter into zero order kinetics. Okay, but these are the common ones which we encounter, so that's why you have to remember. That's it. Okay, so you have your tolbutamide. Okay, you have your thiophylline. You have your thiophylline. Okay, then you have your phenytoin. Okay, all right, aspirin or alcohol also you can write. Okay, so the mnemonic is 0 for zero order kinetics, WAT, WATT for the drugs, power for phenytoin. Okay, so all of you know this mnemonic, I guess. Okay, so just for your recall, it is higher doses which will enter into the zero order kinetics are these ones. So once we understood about this, so pharmacodynamics is a chapter where pharmacodynamics, we are not going to do much of that in here, because pharmacodynamics is a chapter where a lot of the information you are going to learn only throughout the classification of the drugs only. Okay, so from the general pharma, what are the important topics I felt I have touched them. Okay, let's get into the next important concept. What is that? Into your autonomic nervous system. Autonomic nervous system. So autonomic nervous system, quickly I will recall all your autonomic nervous system. Autonomic nervous system can be divided into two types: sympathetic nervous system and a parasympathetic nervous system. Okay, so sympathetic nervous system, when I'm speaking of parasympathetic, so remember, parasympathetic has a cranial and a sacral outflow. So that is why we will call it as a craniosacral. So origin, where does it originate from? Origin is from the two places. Either it originate from the cranial nerves, okay, or it will originate from the sacral nerves. So the cranial nerves are 3, 7, 9, 10. So these 3, 7, 9, 10 are the cranial nerves which play a role in what? Parasympathetic nervous system. Okay, so sacral plexus, all the sympathetic nervous system origin will occur from where? Yes, either it will or it is for the thoracolumbar outflow. Thoracolumbar outflow means thorax and the lumbar area. Okay, so sympathetic, first and most important, neurotransmitters. Neurotransmitters. Okay, neurotransmitter in the sympathetic at the preganglionic, okay, so preganglionic neurotransmitter, अगर मुझे आके कोई सर is this 4 hours sufficiently enough for FMG exam, आपको ही पता है. Okay, so preganglionic neurotransmitter is acetylcholine in sympathetic nervous system. The question you are asking, first think about this. Okay, so 4 hours, 2 hours, they're emergency rescue for you people. Okay, all right, so at a organ level, okay, you have your noradrenaline mainly, then you have your adrenaline, and then you have your dopamine. Okay, then the next one we have, what we need to understand here, for both pre and the organ, pre and the post ganglionic, for both of them the neurotransmitter is acetylcholine only. All right, acetylcholine only. For both of them, the neurotransmitter is what? Acetylcholine only. So sympathetic neurotransmitters are adrenaline, noradrenaline, and dopamine. Okay, the main important receptors in the sympathetic nervous system. Receptors which play a role in the sympathetic nervous system are adrenoreceptor. Adrenoreceptors. Which one? Adrenoreceptors. Okay. So here main one is acetylcholine receptor. Acetylcholine receptor. So these acetylcholine receptors are your cholinereceptors. Cholinereceptors. What is that? Cholinereceptors. What is that? Cholinereceptors. So we have adrenoreceptors and also we have our cholinereceptors. Okay. All right. Acetylcholine receptor का दूसरा नाम है cholinereceptor. So all of them are divided into two types: N cholinereceptor, and M cholinereceptor. So N cholinereceptors are further classified into NN and NM. Okay, NM, neuromuscular junction. Okay, so they are located in the neuromuscular junction. They are located in the neuromuscular junction. Where they are located? NM. M stands for muscle. Muscle में कहाँ पे? Neuromuscular junction. Which location? Neuromuscular junction. NN are located in the ganglion. NN are located in the ganglion. M is further divided into M1, M2, M3, M4, and 5. Okay, M4 and M5 exclusively found only in the central nervous system. M1 to M5, all the subtypes can be found in the central nervous system, and means M1, M2, M3, they're present in the brain. Along with the brain, they're present in the other places. What are the other places? M1 is located in the parietal cell, mainly. Parietal cells. Okay. Then M2 is located on the heart. In all other places, in all other organs, where are the other organs? You take eye, you take a brain, for example, you take the glands, you take the smooth muscle, you take any organ. If there is a parasympathetic innervation is there, if there is a parasympathetic nerves, if they are there, the effect will be seen with the M3 receptors only. Effect will be seen with what? M3 receptors only. All the adrenoreceptors are further divided into alpha adrenoreceptor and a beta adrenoreceptor. Okay, so this is a story of your, what is that? Story of your basic recap of the autonomic nervous system, which is important from pharmacology. Okay, so let's start off with the parasympathetic nervous system related drugs. Okay, first important drugs are cholinomimetics. What are those? Cholinomimetics. Okay, so cholinomimetics. To understand that, cholinergic neuron is important. So which one? Cholinergic neuron. Which neuron? Cholinergic neuron. So cholinergic neuron. So cholinergic neuron means here the neurotransmitter is going to be acetylcholine. Okay. Now acetylcholine. So acetate will combine with a molecule called as choline in the neuron. It will form, what is that? It will form a acetylcholine. So this acetylcholine will come and get stored inside a vesicle. Whenever this receptor, whenever this nerve will get activated, because of the voltage which is coming along the membrane, it will allow the entry of calcium. It will allow the entry of calcium. This calcium will go and act on the vesicle. Vesicle will undergo exocytosis. Exocytosis means release of acetylcholine. So basically acetylcholine comes here. Okay. Now this post-synaptic membrane can be any place. Means if post-synaptic membrane, if it is parietal cell, which receptor would be there? M1 will be there. If it is heart, M2 will be there. Okay. If it is a gland or a smooth muscle, M3 will be there. If it is a neuromuscular junction, it will be NM is possible. Yes, if it is a, for example, autonomic ganglia, NN receptor is going to. If it is a brain or somewhere else, M4, M5 can be present. Okay, so this is the story. So depending on the location, the receptor will change. That's it. Okay, so now this acetylcholine will come and act wherever the location, wherever this neuron got activated, that will come and release the acetyl. Now acetylcholine once released, acetylcholine will not remain there only. It will break down into acetate and choline. So this acetate and choline breakdown is done by acetylcholine esterase. Okay, acetylcholine esterase. Okay, so any drugs which increase the acetylcholine, will stimulate more of this cholinereceptor, right? Or I can have a group of drugs which will directly stimulate the cholinereceptor, possible. So depending on that, we have direct acting and indirect acting. We have a direct acting and a indirect acting. Okay. So direct acting and indirect acting are very, very important questions, because a lot of questions associated with myasthenia gravis and all has been asked from here. Okay. So the direct acting drugs, So direct acting drugs, we have drugs such as carbachol. We have a drug called as carbachol. Okay. With the classification. So first let's do all the direct acting drugs. Okay. So with the classification, let's write down where it is the drug of choice and how to tackle the answer. Okay. So we have a carbachol. Okay. We have a methacholine. Okay. We have a bethanachol. So either their name will have choline or chol in them. Okay, their name will have bethanachol. Okay, choline or chol in them. Okay, carbachol, bethanachol. Okay, so what else is there? Ceremelin. A drug will be there. Ceremelin. We have a drug called as pilocarpine. Okay, so these are these things are there. Okay, carbachol and bethanachol, among which this is the bethanachol is the drug of choice for post-operative urine retention. Betanacol is the drug of choice for post-operative urine retention. Post-operative urine retention. Okay, urine retention. Okay, if not there in the answer, if not given in the options, okay, then you can go for your carbachol. Okay, so carbachol. Okay, so post operative urine retention and also post operative intestinal obstruction. Post operative intestinal obstruction, this is the drug of choice. Okay, cevamelin is the drug of choice for treatment of dry mouth. Dry mouth in which condition? Dry mouth in the Sjogren's syndrome. Which syndrome? Sjogren's syndrome. Okay, these are few important uses. Okay, then the methacholine, my dear students, is not used clinically commonly that much nowadays. Earlier in the older times it was used for arrhythmia treatment, and also it is used in methacholine challenge test. Methacholine challenge test. Okay, so this is a story of your what is a direct acting drugs. Let's go to the next one, indirect acting drugs. Which drugs? Indirect acting drugs. Indirect acting drugs, they inhibit the acetylcholine esterase. Because they're blocking the name of the enzyme is acetylcholine esterase. These drugs are called as what? Anticholinesterases. What are they called as? Anticholinesterases. Okay, they're called as what? Anticholinesterases. Okay, because you'll always get confused between the anticholinergic drug and anticholinesterase. So I don't want you to get confused between the anticholinergic and anticholinesterase. So anticholinesterase basically cholinomimetics only. Okay, so these are they're increasing the acetylcholine. If they're increasing the acetylcholine, acetylcholine will act upon both M receptor also. Acetylcholine will act upon both N receptor also. So now the direct acting drugs, all the direct acting drugs, remember they act only on, they stimulate only which receptor? M receptor. Okay, so what is the advantage of these drugs? Indirect acting, they stimulate both M and N receptor. They stimulate both the M and N receptors. Okay, so since they are stimulating the both M and N receptor, so please listen to me. These drugs, we have so many drugs are there. So what are the drugs we have? Edrophonium. What is the drug we have? Edrophonium. Okay, now edrophonium is the first drug. Where do we use it? Edrophonium is used for a test, that is only your penicillin test. What is the name of the test? Penicillin test. Okay, let me get an image for you people. Okay, so just 1 second, I'm adding that image. Okay, so that it will be understood very easily. Okay, so Tensilon test. Where do we use Tensilon test? Tensilon test is used in myasthenia gravis. Tensilon test is used in myasthenia gravis. Okay, so after giving it, so patient with myasthenia gravis, okay, drooping of eyelids is there, all the severe symptoms is there. Now after giving a edrophonium, automatically you can see improvement of the symptom. So if improvement, this is a Tensilon positive. This is a Tensilon positive, that is suggesting of what? That is suggesting you that, what is it suggesting you? Positive. That suggest means it is a case of myasthenia gravis. Tensilon test, if it is positive, myasthenia gravis. Tensilon test, if negative, okay, if negative, and patient is on the treatment of patient is on the treatment of myasthenia gravis, and the Tensilon test is negative, that is suggesting you of myasthenia crisis. Okay, myasthenia crisis. This is a This is a very severe condition where we have to treat them very quickly, okay? Because it can lead to worsening of the symptoms and even cause the death of the patient. So that is why myasthenic crisis. So if myasthenia gravis, drug of choice for myasthenia gravis, always remember the best answer is your pyridostigmine. 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 Okay. So what is the drug of choice? Pyridostigmine is a better option than the neostigmine. Neostigmine. Okay, so both of them, they do not cross the blood brain barrier, and in the brain also we don't have any skeletal muscle. We require the effect only in the periphery where skeletal muscles are there. That is why we are giving the drug. We are giving the drug which does not cross the blood brain barrier. Very good, guys. This is the correct answer. Okay, so pyridostigmine and a neostigmine are the drugs we have here. Okay, so drug of choice for the myasthenia gravis. Okay, so edrophonium test. Okay, which is the drug used? Edrophonium. The name of the test is tensilon test. Drug of choice for myasthenia gravis is this one. And recently pucha hua question tha. So let's go through other treatments of myasthenia gravis. Other treatments of myasthenia gravis. Okay, so other treatment of myasthenia gravis. So one of the most important drugs which can be considered is your steroids. Okay, which can be considered is your steroids. So they're not a first line. They're not a first line. Always the drug of choice is, of course, pyridostigmine. Other treatments which can be considered. Okay, that is one thing is there. Okay, and also remember azathioprin can be used. It is a immunosuppressant. It is a immunosuppressant. Azathioprin. Basically, myasthenia gravis is a disorder in which autoimmune antibodies are there. These antibodies were coming and binding with the NM receptor. So basically, we are suppressing the immune system. So if immune system is suppressed, autoantibody production will be reduced. So that is why we are giving immunosuppressant. And if you find a myasthenic crisis, you can also go for plasmapheresis. Plasmapheresis is also useful. Okay, so these are the treatments available. So they had asked one question previously. What was the question? Which of the following are used in the treatment of myasthenia gravis? Except the first one is used is always pyridostigmine only. If pyridostigmine is not there, you can choose, or depending on the scenario, you can go for this one. Okay, what is the investigation of choice for gold standard investigation? Anybody? Gold standard investigation. Okay, so investigation of choice, you can search for autoantibodies. One more, you can do edrophonium test. Edrophonium is a old test. Okay, nowadays single fiber electromyography. Okay, single fiber electromyography. Single fiber electromyography. Okay, this is a advanced investigation we have now. Okay? Single fiber electromyography. Okay, single fiber electromyography. Okay, so that is the thing which you have to do. Okay, EMG, electromyography. Which one? Single fiber electromyography. Okay. All right. So once we understood about the acetylcholine, so the next important concept oriented questions here is so that is a drug of choice for donepezil. Drug of choice for Alzheimer disease. I'm sorry, confused by mistake. So what is that? Alzheimer's disease. So Alzheimer's disease current drug of choice. We don't use rivastigmine. We don't use statin due to their adverse drug reaction profile. Right now, the drug of choice is which one? Donepezil. What is that? Donepezil. That is the drug of choice. Okay, and that is a drug of choice for Alzheimer's disease. Okay, हो जाता है, ठीक है, कोई नहीं. All right. Once we understood about the drug of choice for Alzheimer is donepezil. So these are the few important key points which has been frequently asked. So that revision has been done. Okay. So now once we are done with it, we will continue from the cholino blocker. We'll continue from the cholino blocker after taking a small short break, because if I just go on dumping the drug names for you, after 10 minutes, you will not like me anymore. Okay. So we had planned 4 hours. If needed, we can go for 1 more hour further. That won't be an issue for us. We will do it. Okay. We'll take a short break of 10 minutes. Okay. Okay. So now we are audible. Perfect. Let's continue. So we are done with the discussion of what is the drug of choice for the treatment of Alzheimer disease. The drug of choice for the Alzheimer disease is donepezil. Okay. So quickly I'll tell you from pathology point of view and medicine point of view, Alzheimer is a senile disease. It's a old age disease. It is associated with the formation of neurofibrillary tangles in the brain, and also there is a tau protein accumulation will be there. And apart from that, this Alzheimer disease, microscopically when you are looking, there is a decreased level of acetylcholine neurotransmission. Okay, and also you are going to find a inflammatory changes in the brain. Okay, and also shrinkage of the brain will be possible. Okay, anyways, let's continue. Okay, so what is the next important aspect which I want you to listen to me is that is your cholinoblockers. Okay, so cholinoblockers are a group of drugs which will always block the M receptor, If M receptors are being blocked, automatically what will it lead to? If M receptors are being blocked, okay, so what will happen? Audio came back, I think now. Okay, if M receptors are blocked, automatically they will block the parasympathetic activity. Don't worry about the organophosphate poisoning. Okay, actually I had done one complete video of poisoning and their antidote on our Meduhub app itself. I mean YouTube channel itself. You can go through that from the live, because all the important antidotes and the poisons have been covered from there. Okay, so that is why I'm trying to remove that aspect as much as possible. Okay, so now let's continue to the next one. Okay, that is your M cholinereceptor blocker. So M cholinereceptor blocker in the central nervous system. So M receptors which are present in the central nervous system are M1, M2, M3, M4, M5. Okay, so they are located in the multiple areas. So one of the most important drug which you need to discuss for the cholinoblockers from the central nervous system is hyoscine. What is the name of the drug? Hyoscine, which is also called as scopolamine. What is the name of the drug? Hyoscine, which is also called as scopolamine. Okay, scopolamine is a drug of choice. It is used in the form of a transdermal patch. What is that? A transdermal patch. Okay, so it is used in the form of a transdermal patch. It is given at least 3 to 4 hours before the start of journey. So before the start of the journey, so the patient has to take this patch. Okay, so why? For the treatment of motion sickness. It is used for the treatment of motion sickness. Okay, so motion sickness. All right, so whenever they're giving a motion sickness, you need to look at the two things here. What is the two things you are going to look at? One thing you are going to look, my dear students, is you are very importantly, yes, what is going to do? So if at all we are looking at the duration of journey, less than 24 hours duration of journey, less than 24 hours is the duration of journey. So if it is less than 24 hours is the duration of journey, my dear students, the better preferred drug is your promethazine. Actually, what is a drug which is preferred? Promethazine. What is promethazine? Promethazine is a antihistamine. Okay, and anticholinergic drug. Antihistamine and a anticholinergic drug. Okay, so it blocks the. Actually, it is a, what is that? Antihistamine with a high property of strong anticholinergic properties also there. That is why we are using this promethazine. If more than 24 hours is the duration of journey, then the drug of choice, better one will be scopolamine. Okay, so scopolamine. This is the story of your central nervous systems. Okay, then let's go to the next one. The next place, the drugs we have are trihexyphenidyl. What is the name of the drug? Trihexyphenidyl. Okay, which is also called as benzhexol, Okay, now we also have one more drug, benzatropine. So we have benzatropine and benzahexol. Okay, so benzatropine and benzhexol. So these two are the in the central nervous system. They're the drug of choice for, yes, they're the drug of choice of what? Yes, drug induced Parkinsonism. Drug induced Parkinsonism. Parkinsonism. Okay, so drug-induced Parkinsonism. Let me give few key important aspects to be remembered. So drug of choice for that. So now when we are speaking of drug-induced Parkinsonism, so drug-induced Parkinsonism is also a very important concept. Drug-induced Parkinsonism. Okay, so drug-induced Parkinsonism is a condition caused due to, causes, which drugs will cause a drug-induced Parkinsonism. So if they give you a question, you should be able to read the question. You should be able to find out which drug has caused it. Okay, mainly any drug which is a D2 blocker, D2 blocker. So D2 blocker. So in the brain, if any drug which blocks the dopamine receptors, they can lead to drug-induced Parkinsonism. Okay. So in the drug-induced Parkinsonism, D2 blocker, if they give you, so most importantly, what happens? D2 receptors are blocked because of that increase of acetylcholine activity. So basically in the brain, we have a balance between the dopamine and acetylcholine. I have blocked the dopamine receptor, dopamine activity has gone down. If the dopamine activity has gone down, automatically acetylcholine activity is more. So because of that, they're getting the drug-induced Parkinsonism. So what are the clinical features? What are the clinical features? So the clinical features, my dear students, you need to remember one important aspect. What are the clinical features we are going to get? So the first and most important clinical feature which you can encounter is this one. What is that? That is extrapyramidal symptoms. So what are the extrapyramidal symptoms? Such as dystonia. What is that? Dystonia. This is the first clinical feature associated with the drug-induced Parkinsonism. All of them falls under something called as EPS, extrapyramidal symptom. Extrapyramidal symptom. Okay. Dystonia. Okay. Apart from dystonia, what else can occur? Okay. So the patient is going to get tardive dyskinesia. Tardive dyskinesia. Okay. Then patient can also get akathisia. Okay, so akathisia, these are the clinical features, and they can also develop something called as perioral tremors. What is that? Perioral tremors. So these are the clinical features associated with your extrapyramidal symptom. So what are the D2 blockers we have? D2 blocker, mainly two major drugs you need to remember. One drug is your metoclopramide. Okay, and one more drug what you have, my dear students, is your antipsychotic drugs. Okay, antipsychotic drugs. Okay, so these are the drugs. So basically they'll give you a patient who was diagnosed case of schizophrenia, was treated with the antipsychotic, develops dystonia, tardive dyskinesia, akathisia. What will be the drug of choice? You're going to go for the trihexyphenidyl. Okay, why? Because there is an increased acetylcholine activity. These drugs are cholinoblocker, they block the cholinereceptors. Okay, so that is the story of your, what is that? Central nervous system. So once we understood about the central nervous system, let's go to the next important point where we need to understand in the, let's start with the heart. Okay, on the heart, normally M2 receptor will be there. If you stimulate the M2 receptor, there will be decrease of heart rate. There will be what? Decrease of heart rate. If you block the M2 receptor, there is an increase of heart rate. So basically, our cholinoblockers are blocking your which receptor? M2 receptor. So the drug we have is atropine. Atropine. Don't forget, we are studying the M receptor blocker. We are not studying the stimulant. Stimulant we have studied previously already. Okay, atropine. Where do we use? It is a drug of choice in few conditions. One of the place where it is drug of choice is bradycardia. Okay, bradycardia. Okay, it is also drug of choice for AV block. It is also drug of choice for AV block with respect to the heart. Okay, but treatment of choice for the AV block is always pacemaker. The drug which can be used during the AV block is your atropine. Okay, so that is the story of your heart related. Okay, once we understood about the heart, let's go to the other places in the respiratory system. In the respiratory system, M3 receptor will be there. If you stimulate M3 receptor, there will be bronchoconstriction. So but we are studying which drug? M3 blocker. M3 blockers are the ones which will cause bronchodilation. Okay, so since they're causing the bronchodilation, where do we use? They're used in COPD and bronchial asthma. Okay, so what are the drugs we have? M3 blocker surgery. M3 blockers we have ipratropium. Main commonly used drugs are ipratropium. Okay, and you have one more drug is called as the thiotropium. Okay, among which they can ask you the very common possibility, one more possible MCQ. Which of the following is a longer acting M3 blocker? Longer acting M3 blocker possibly is which one? Thiotropium is a long acting drug. Okay. All right. So let's go to the next one. Okay. So let's go to the next one. Okay. So what is the next one we are going to understand? The next important one I want to teach you people only about the bladder. Only about the bladder. So M3 receptors are located in the bladder. Okay. And the detrusor muscle. Okay. Detrusor muscle. Okay. So basically if you activate the M3 receptor, it will contract the detrusor muscle. So since there is a contraction of detrusor muscle, person will be able to urinate very easily. Okay. So parasympathetic activation causes what? Yes, that will cause the urination. This will cause the urination. Then if you block the M3 receptor, automatically it will relax the detrusor. Relax the detrusor. If it relax the detrusor, automatically it will decrease the frequency of urination. Frequency of urination. Okay, so if they are decreasing the frequency of urination, these are used in the treatment of hyperactive bladder. These are used in the treatment of hyperactive bladder. Hyperactive bladder. Okay, so among the hyperactive bladder, what are the drugs we have for the treatment of hyperactive bladder? That is M3 blockers, which are available selective to bladder. More selective to bladder include your oxybutynin. Oxybutynin. Okay, we have tolterodine. Tolterodine. We have solifenacin. Solifenacin. Okay, you have your dorifenacin. Dorifenacin. Okay, then you have one more drug, trospium. Okay, so they won't give all the drugs and ask you the best one. So hyperactive bladder, one group we can use is M3 blocker. One group which can be used is M3 blocker. M3 blockers. Okay, so among which commonly used is oxybutynin, if not dorifenacin, are the two commonly asked drugs. Okay, then the next point which you need to remember, so other drugs for hyperactive bladder. Other drugs for hyperactive bladder. Okay, in the hyperactive bladder. Okay, so what are the other drugs which are used in the hyperactive bladder are a commonly asked question. So they can ask you all of the following groups are useful in the treatment of hyperactive bladder except, okay, when there is a 2 or 3 options for the treatment options for anything, so there is a high likely you are going to get it as a MCQ. Okay, I hope everybody is able to follow. Speed is not that much, I am hoping. Okay, so able to follow, yes or no? Give me in the comments, everyone. So other drugs is your beta 3 agonist. Beta 3 agonist. Okay, we have a drug called as mirabagarone. Mirabagarone. Okay, and also we have one more drug called as vibagarone. Okay, so apart from that, we can also use tricyclic antidepressants. Which other drugs can be used? Tricyclic antidepressant. So tricyclic antidepressants are a group of drugs which are going to be useful where? Which are going to be useful. Yes, yes. In the treatment of tricyclic antidepressants, which drug hyperactive bladder में, but which one they can ask you? Imipramine. What is the drug? Imipramine. Among all the antidepressant, tricyclic antidepressant, the best one here we can follow is imipramine. Which one? Imipramine. Okay, so that is the story of your, what is that story of your hyperactive bladder. So last organ which we haven't discussed yet is your eye. So in the eye, M3 receptors are there. M3 receptors, they are present on the dilator pupillae. On the dilator pupillae. Okay, so dilator pupillae. Sorry, constrictor pupillae. I'm really sorry. They're located in the constrictor pupillae. They're located on the constrictor pupillae. Which receptor? M3 receptor. If I stimulate the M3 receptors on the constrictor pupillae, they are going to cause meiosis. Meiosis. Okay, now what will happen because of the stimulation? Okay, what we are using? M3 blocker. If I give M3 blocker, it will inhibit the constrictor pupillae. It will inhibit the constrictor pupillae. So because of this, so basically in the eye also we have two groups of muscles. One is constricting muscles, one is mydriatic muscles. Some few muscles are there which will cause the mydriasis, few of them will cause the meiosis. So now meiosis is not occurring. So they are also under a balance. They are also under a balance. So if they are also under a balance, if I block the constrictor pupillae, automatically because of that now dilator pupillae will become more active. Dilator pupilla becomes more active. So dilator pupilla becomes, if it more active, it will cause mydriasis. Okay, but the problem here is that directly we did not stimulate the dilator pupilla. Rather, we stimulated the dilator pupilla by blocking the constrictor pupilla. By blocking the constrictor pupilla, dilator pupilla becomes active. So because of that reason, we are getting a passive mydriasis. Passive mydriasis, and along with that there is a possibility of cycloplasia. Why cycloplasia, bacho? Because cycloplasia will occur because of what? Cycloplasia will occur because these M3 receptors, they are also located on your ciliary muscle. Ciliary muscles, if they become blocked, automatically it will lead to paralysis of the ciliary muscle, called as cycloplasia. Okay, we have tropicamide. Tropicamide is a short-acting drug. Tropicamide is a short-acting drug which is used in the adult patients. Okay. They have your atropine also can be used in the eye. Atropine, my dear students, we have, what is that? Atropine is a long-acting drug. It is useful only in the infants. Because in the infant, ciliary muscles are very strong. If you want to cause mydriasis in the infant, you are supposed to use long and very powerful drug, also very strong, very potent drug. Compared to tropicamide, atropine is a long and strong, you can remember like that. Okay, it's just a more potent drug which will cause mydriasis very strongly in the children. Okay, so this is a story of your atropine and tropicamide. Okay, so once we understood about that, we are done with the important aspects related to, yes, that is your done. Which one? Cholino blocker. Let's go to the next one, adrenomimetics. So when we want to discuss about adrenomimetics, let me quickly give you an idea of what is that adrenoreceptor. Adrenoreceptors are divided into two types, alpha adrenoreceptor and beta adrenoreceptor. Alpha adrenoreceptor is divided into further alpha 1. Alpha 1 receptor is further divided into alpha 1a, alpha 1b, okay, and also alpha 1d. There is no alpha 1c, so alpha 1a, 1b, 1d. Okay, so alpha 1a receptor, where is alpha 1a is located? It is located in the urinary bladder sphincter. Okay, we'll discuss beta after alpha. Okay, if I stimulate alpha 1a, urinary bladder sphincter will close, so that will decrease the frequency of urination. Okay, then you have alpha 1b. Alpha 1b receptor is located on the blood vessel. Alpha 1b located is in the blood vessel, and alpha 1b is located also in the dilator pupillae. Okay, so where and all it is located? Alpha 1b, blood vessel and dilator pupillae. So the blood vessel, if it activates, it will cause vasoconstriction and increase the blood pressure. Okay, if at all I'm doing a dilator pupillae, if it gets activated, it will cause mydriasis. So basically, smooth muscle, blood vessel is a smooth muscle, urinary bladder sphincter is a smooth muscle. Everywhere urinary bladder sphincter is also closing, blood vessel is also undergoing vasoconstriction, dilator pupilla is also contracting, leading to mydriasis. So basically, alpha 1 receptor predominantly located where? It is located predominantly on the alpha 1 receptor is located on the smooth muscle. Everywhere in the smooth muscle, it will cause the contraction of the smooth muscle. Okay, alpha 1d is also located on the blood vessel. Okay, then let's go to the next one, alpha 2. Alpha 2, basically it is located on the presynaptic. Alpha 2 is a very important receptor, presynaptic receptor. Okay, presynaptic receptor. Okay, this presynaptic receptor, if I activate this presynaptic receptor on the alpha 2, so that will decrease the sympathetic activity. How it will decrease the sympathetic activity? It will decrease the release of norepinephrine. Okay, so basically, if you stimulate alpha 2, sympathetic activity will be reduced. Okay, so alpha 2 stimulants will always lead to reduction of the sympathetic activity. So alpha 2 agonist can be used for the treatment of hypertension, because sympathetic activity, if it reduces, automatically it will reduce the blood pressure. Okay, I hope everybody is able to follow. Okay, alpha 2 is even located in the blood vessels as well, but this much is sufficient for you people. Okay, all right, so let's continue to the beta receptor. Beta receptor is further divided into beta 1. Beta 1 is located mainly in the two places. One is in the JG cells of the kidney. JG cells of the kidney. In the JG cells of the kidney, basically they're doing what? They will release the renin. The keyword is release. Okay, they do not synthesize the renin. Activation of beta 1 cell will not synthesize the renin, rather it will cause the release of renin. The keyword is release. Okay, so the release of the renin is caused by what? JG release of the renin in the JG cells is caused by beta 1 receptor. Then the next one location is always your heart. Okay, very good. They are located in the kidney. Correct answer. Okay, so heart. In the heart, my dear student, what will it do? First, let me go back here. Before heart, here they will release the renin. Renin release will stimulate the system called as RAS system. RAS system stimulation will lead to increase of the BP. Okay, RAS system activation will lead to increase of the BP. In the heart, which receptors are located? Beta 1 is located. If you activate the beta 1 on the heart, it will increase the heart rate. It will increase the force of contraction. Okay, force of contraction of the heart, and also it increase the O2 demand of the heart. Means heart will work more and ask for more oxygen. Ask for more oxygen. Okay, so this is a story of your what is that beta 1 receptors which are located on the heart. If they're activated, this is what is the effect you're going to get. Okay, so once you understood about that beta 2, my dear students, remember the keyword. They're what? They're basically located on the smooth muscle. But which smooth muscles you need to remember? The first smooth muscle, they're located in the bronchus. They're located in the bronchus. Okay, beta 2 receptors are located in the smooth muscles of the blood vessel, and also they are located on the uterus. Okay, so bronchus, what is the locate, what happens if I stimulate the, yes, of course, if I stimulate the beta 2 on the bronchus, it will lead to bronchodilation. It will lead to bronchodilation. Blood vessel also, if I activate which one? Blood vessels beta 2 receptor, it will also lead to vasodilation. So basically, if you notice, so beta 2, if you are looking, beta 2 everywhere in the smooth muscle, it is getting the same effect, that is relaxing the smooth muscles. Okay, then uterus, in the uterus also, if these two receptors are beta 2 is stimulated, they will relax the uterus. This will be useful in the treatment of preterm labor, but beta 2 agonist not used anymore in the treatment of this one. What is that? Uh, Premature labor. Okay, I'll explain that in the beta 2 agonist. Don't worry. I'll explain. Okay, let's go to the first one. That is adrenomimetics. What is that? Adrenomimetics. What are adrenomimetics? Adrenomimetics are a group of drugs which will stimulate the sympathetic nervous system. They will stimulate which nervous system? Sympathetic nerve. If they're stimulating the sympathetic nervous system, so automatically they will lead to what? Sympathetic nervous system will get activated. Sympathetic activation will lead to one important aspect. What is that? Activation of the sympathetic nervous system. So because of the activation of the sympathetic nervous system, so basically there is a activation of alpha and beta receptor. Okay, so because of that we are going to get all these effects. Okay, so adrenomimetics will cause the increase the heart rate, okay, bronchodilation, vasodilation, uterine relaxation, okay, they decrease the blood pressure, okay, and also they're useful in the dilation of pupil, okay, they can also increase the BP. All of these effects can be produced. Okay, so the first drug which you need to remember is adrenaline. Okay, adrenaline, all the important key points and their uses, let's go through. Okay, adrenaline, my dear student, it will stimulate alpha 1, it will stimulate alpha 1, alpha 2, stimulates beta 1 and beta 2. Okay, so it will stimulate all the types of adrenoreceptor. Okay, if it is stimulating all the type of adrenoreceptor, adrenaline, if it is at a high concentration, adrenaline at a high concentration, it has more action stimulation of alpha 1 receptor. Adrenaline, whenever it is in a large quantity, always activate the alpha 1 receptor. Adrenaline at a low concentration, will activate the beta 2 receptor, and these two effects are only we are looking at on the blood vessel, because adrenoreceptor alpha receptor is located on the blood vessel. One is increasing the BP, yes, and one more beta 2 which is located on the blood vessel is decreasing the BP. So when it will decrease, when it will increase, so when more adrenaline is there, increase of BP. When less adrenaline is there, action on the beta 2 receptor. So because of that, if adrenaline if given IV, Adrenaline if given IV. Adrenaline if given how? IV. If I give a adrenaline IV, what will happen? Okay. Adrenaline, as soon as I give a IV, adrenaline in the blood vessel, it is in a large quantity. On the blood vessel, in the blood vessel, large amount of adrenaline. Adrenaline if given IV. So we are tracking the BP of a person. Let's imagine this is the BP of a normal healthy individual we are tracking. So I gave a adrenaline. I gave it which drug? Adrenaline. I gave which drug? Adrenaline. As soon as I give adrenaline, what is going to happen? So as soon as I give adrenaline, initially adrenaline, as soon as I inject adrenaline is in a large quantity in the blood vessel, automatically large quantity means it will activate the alpha 1 receptor, leading to the increase of the BP. After some time, adrenaline will start to break down. So adrenaline concentration will come down and BP will also come down. Adrenaline, after some time, it will become into low concentration. Adrenaline, once it becomes into the low concentration, there is a fall of the BP, then it will come back to the normal. So initially at a high concentration, adrenaline activated alpha 1 receptor. Adrenaline at a low concentration activated a beta 2 receptor. Okay, alpha 1 activation caused the vasoconstriction and beta 2 activation caused the vasodilation. So this is only called as biphasic response of adrenaline. Biphasic response of adrenaline. Response of adrenaline on the blood vessel. So you need to remember, on the blood vessel it is biphasic response. Okay, so now there are some there are some potential question which can be asked, and there are few previously asked question. So adrenaline and alpha blocker is there. Adrenaline and alpha blocker, if it is there, what will happen? Let's see. Okay, so what is happening? So now listen to me. I'm checking the BP of a person. I'm checking what? BP of a person. When I'm checking the BP of a person, what is the drug I'm going to give here, my dear students? I'm going to give adrenaline. Of course, I'm going to give adrenaline. But along with adrenaline, I'm giving you and also alpha blocker. Alpha blocker means alpha receptors have been blocked. Okay. So if alpha receptor will block, now what is the response you are going to get? Bacho, is only this much. Okay, why? Adrenaline and alpha blocker. Look here, initially the response was coming due to alpha 1 receptor. Now alpha receptors will block. If alpha receptor will get blocked, automatically there will be only response will come from beta 2 only. Response will come from beta 2 only. So this phenomenon of if adrenaline given with a adreno blocker, automatically that will decrease the blood pressure. So this phenomenon is only called as the reversal of Del. Which reversal? Automatically we are looking at blood vessel. So vasomotor reversal of Dales. Vasomotor reversal of Dales. Vasomotor reversal of Dales. Okay. Then we have next one. Next one, my dear students. What is that? That will be where if you give a adrenaline and a beta blocker. Adrenaline and a beta blocker. Okay. What will happen? Let's see. So we are giving the adrenaline and a beta blocker. Adrenaline and a beta blocker. So if I give a beta blocker, automatically now only alpha receptor will work, but beta receptor won't work. Beta receptors are not working. Automatically what will happen? The second response will not be seen. So this is only called as re-reversal of Dales. It's only called as re-reversal of Dales. Okay. So this is a story of your Dales phenomenon. Okay, so once we understood about the Dales phenomenon, let's go to the adrenaline. Okay, so first drug we are going to discuss the adrenaline. Adrenaline is a catecholamine. Adrenaline, noradrenaline, dopamine. These are the naturally existing catecholamines. Okay, the first one we are starting is adrenaline. Adrenaline, where do we use, my dear students? Okay, so adrenaline is a drug of choice for anaphylactic shock. What is it? Anaphylactic shock. Anaphylactic shock. Okay, so it is given in a dilution ratio of 1 in 1000. Okay, 1 in 1000. It is always given intramuscularly. So this dilution we are going to give 0.5 ml. Simple as that. This dilution adrenaline we are giving 0.5 ml. Okay, it is also useful in what? It is also useful in bronchial asthma. Bronchial asthma. So here we can use adrenaline inhalation. Inhalation. Usually preferred dilution is 1 in 100. For inhalation, what is the preferred dilution? 1 in 100. Then it is also useful in the resuscitation of cardiac arrest. So during the cardiac arrest, we are trying to reactivate the heart. So we are going to use this. So we are going to use adrenaline in a IV fashion, 1 in 10,000. 1 in 10,000. Okay, 1 in 10,000. Okay, So 1 in 10,000 is the dilution ratio which we are using in what? We are using in the IV, that is for the cardiac arrest. Okay. Then it is also used for duration prolongation of local anesthesia. Duration prolongation of local anesthesia. Basically, if you give adrenaline and your local anesthetic, so what will happen? So adrenaline will cause the vasoconstriction. So now you are giving a local anesthetic in the place of wound. There all the vessels will undergo vasoconstriction. Automatically what will happen? Local anesthetic will remain there only in the site of wound, so the duration action will be more. Okay. So that is the story of your duration prolongation of anesthesia. Okay. It is also used in the epistaxis. It is also used in the epistaxis. So this is the story of your adrenaline. Okay. Now adrenaline we are done. We are going for noradrenaline. Noradrenaline is the drug of choice for shock. Drug of choice for shock, because noradrenaline has no action on the beta 2 receptor. Since it has no action on the beta 2 receptor, it will act only on the alpha receptor. So since it will act only on the alpha receptor, so it is a drug of choice for shock. Okay. Then so if they don't mention the type of shock, they haven't mentioned the type of shock. What type of shock they didn't mention. So blindly they asked you a question about shock, anaphylactic, blindly shock. Blindly shock, drug of choice is noradrenaline. They specifically mention the shock, then adrenaline. Okay. So that is the story of your this ones. Okay. Then let's continue to the next concept. What is the next concept? So no action on beta 2 and there is no significant change of heart rate. No significant change of heart rate. This is also very important. So these are the two important because of its activation of C. It is a very strong vasoconstrictor. It is a very strong vasoconstriction. That is why, yeah, if there is a vasoconstriction, BP will rise. The next one, see, in a normal individual, if you give noradrenaline, it will cause vasoconstriction so much that it will activate the baroreceptor. Okay, so because of the effect of baroreceptor and noradrenaline effect on the beta 1 receptor, you are not going to find the significant change of heart rate. This is the story behind the noradrenaline. Okay, then let's go to the next one. Next one, adrenaline, noradrenaline is done. So in the acute heart failure, I'm going to teach you about the dopamine. Now we are going to continue to the which one? Alpha agonist. Alpha agonist. Alpha agonist. Alpha agonist are a group of drugs which will activate only alpha receptor. Which will activate only alpha receptor. So alpha agonist which will activate the alpha receptor. We have a drug such as oxymetazoline. Oxymetazoline. Okay. We have xylometazoline. Xylometazoline. Okay. And phenylephrine. Okay, so all of them are alpha 1 agonist. Alpha 1 agonist means they stimulate only alpha 1 receptors. Okay, so if they're stimulating only alpha 1 receptor, oxymetazoline and xylometazoline, they're used as an intranasal spray. Intranasal spray for the treatment of what is that? Nasal decongestant. These are the nasal decongestants. Nasal decongestants. Okay, then phenylephrine. Phenylephrine is also a nasal decongestant. Nasal decongestant. Okay, but and also remember it is used as a mydriatic agent because alpha receptors are located in the dilator pupil. Dilator pupil activation will cause mydriasis. So it is a active mydriasis. Okay, it is a mydriatic. What is the difference there if they ask you? Without cycloplasia. Without the cycloplasia. So mydriasis without cycloplasia is which one? Alpha 1 agonist. Then we have alpha 2 agonist. Alpha 2 agonist you need to remember. Okay, alpha 2 agonist, what are the drugs you need to remember, dear students? What are the important aspects you need to remember? So alpha 2 agonist, so you have clonidine and methyl dopa. Clonidine and methyl dopa. Methyl dopa is one of the drug which is safe in pregnancy induced hypertension. Safe in pregnancy hypertension. Okay, so whenever we are speaking of safe in pregnancy hypertension, so let's understand important the drugs which are safe in pregnancy induced hypertension. Pregnancy induced hypertension, the drug of best drug is labetalol. But if there is a history of asthma, avoid it. If there is a history of asthma, avoid it in the pregnant female, because this is a very important previously asked question. Okay, I'm trying to concise as much as possible content so that you can remember it better. Okay, all right, labetalol. Okay, so the next one is methyl dopa. Next one is a methyl dopa. Okay, the next one which you have are calcium channel blockers such as nifedipine and amlodipine. Okay, prazosin also considered to be safe, but not clinically that much used. Not clinically that much used, but pregnancies of prazosin also considered to be safe. Okay, then you have your what is that hydralazine. Okay, so these are the drugs which are safe in pregnancy, which are safe in pregnancy. So remember with the mnemonic, let me care, pregnancy, hypertension. Okay, so remember like that. L for labetalol, let me care. L for labetalol, M for methyl dopa, C for calcium channel blocker, P for prazosin. Okay, then you have your what is that hydralazine, that is H. Okay, so these are the drugs which are considered to be safer in pregnancy induced hypertension. Okay, that concept is done. Let's continue to the next one. Okay, alpha 2 agonist is done. Okay, then let's go to the next one, beta 1 agonist. Beta 1 agonist. So beta 1 agonist are the group of drugs which will activate a beta 1 receptor. If they activate a beta 1 receptor, they increase the heart rate, they increase the force of contraction. Automatically, because of that, automatically these are the drug of choice for acute heart failure. Acute heart failure. Okay, acute heart failure. Okay, so these are the drugs which are having which effect, positive ionotropic effect, a positive ionotropic effect. Okay, so beta 1 agonist, the drugs which we have is dobutamine, and we have one more drug, dopamine. We have one more drug, dopamine. Okay, now basically dopamine is a very interesting drug. Dopamine will stimulate adrenoreceptor also, and also dopamine will stimulate which receptor, the dopamine receptor also, okay, it is stimulating both of them. If it is stimulating the dopamine receptor also, if it is stimulating the dopamine receptor, it will increase the renal blood flow, it will increase the renal blood flow. So because of increase of renal blood flow, it will increase the urine output, it will increase the urine output. Okay, so it is a nephroprotective agent we can consider. Okay, so dopamine, where will it become a drug of choice? Dopamine is the drug of choice in patient with two cases. Okay, that is your shock with oligouria, shock with oligouria or renal failure, okay, and also dopamine is a drug of choice in acute heart failure with oligouria. So if there is a oligouria and shock or heart failure, the drug of choice will be dopamine. But dopamine has a dose dependent action, so remember this direct keyword. Shock with oligouria, what is the dosage we are going to use is a high dose. Okay, so the medium dose is used for what? Acute heart failure with, of course, your oligouria is the time. Okay, so I am hoping that everybody is able to follow. Do you want me to reduce the speed, my dear students? Okay, shall we continue? Let's continue. Okay, so dopamine, beta 1 agonist done, beta 2 agonist. So beta 2 agonist are the drugs which are divided into two types, SABA and LABA, okay, SABA and LABA, okay. So when we are speaking of SABA and LABA, this you have your salbutamol, okay, you have your terbutaline. What is that? Terbutaline. Okay. Then you have your LABA. LABA is what? LABA is the drugs which are salmeterol, formoterol, and formoterol. These beta 2 agonists are the drug of choice. They're used in, yes, used in bronchial asthma and COPD. Okay, these we have uterine specific. They are mainly acting upon the uterine specific. They specifically act upon the uterus, which causes the uterine relaxation. So we have one drug called as isoxsuprine. isoxsuprine. Okay, and we have one more drug. We have one more drug called as retodrine. What is the name of the drug? Retodrine. So these are the two drugs which are there. So these are earlier used for mainly your as a tocolytic. I used as a tocolytic. Okay, so where we are going to use the tocolytic, there we are going to use it in the preterm labor. Okay, so this is a story of your preterm labor ka kahani. But what are the drugs which we are going to use nowadays? Okay, so for the preterm, okay, so for the preterm labor, what are the drugs which are used? Please listen to me. So during the preterm labor, the first drug which is safe to always use is calcium channel blockers. Which is that? Calcium channel blockers. Calcium channel blocker is the best tocolytic which can be used. Okay, apart from the calcium channel blocker, we can also use atosiban. What is the name of the drug? Atosiban. What is the name of the drug? Atosiban, which blocks the oxytocin receptor. Atosiban blocks which receptor? Oxytocin receptor. Atosiban. Okay, so this is also a tocolytic only. This is also a tocolytic. Usually it is not a drug of choice in any condition, tocolytic, but some cases we can use tocolytic where we cannot use the calcium channel blocker. Okay, then other drugs which we are going to use is corticosteroids. What are the drugs? Corticosteroids. So corticosteroids are the ones which are maturation of the which involved in the mature the fetal lung, which cause the maturation of the fetal lung. Maturation of the fetal lung. So maturation of the fetal lung is done by which drug? Corticosteroids. Which drug? Corticosteroids. So these are the few drugs which are useful in the preterm labor. But not clinically commonly used. Also can use MgSO4. Can use MgSO4. Okay. Yes, MgSO4 also involves in the fetal lung maturation and also a tocolytic. It is both tocolytic and also involves in the fetal lung maturation. So it can be considered. Okay. So if they ask you, be very careful which drug you are. For example, all of the following except if they ask. Okay. So once we are done with that, let's go to the next group of drugs. The next group of drugs is your adrenoblockers. Okay, so adrenoblockers, we have alpha blocker. So when we are speaking of the alpha blockers are divided into two types, reversible and irreversible. Okay, so reversible alpha 1 and alpha 2 blocker, reversible alpha 1 and alpha 2 blocker, and another one is irreversible alpha 1 and alpha 2 blocker. Okay, so these are the two possibilities. Okay, so the questions are there. See, very careful, be very careful here. So what is there? There is a drug called as phentolamine. Okay, then you have a irreversible, we have a phenoxybenzamine. Phenoxybenzamine. Okay, now reversible and irreversible, we have also reversible, we have one more drug called as tolazoline. What is the name of the drug called as? Tolazoline. What is the name of the drug is called as? Tolazoline. Okay, so once we know about that, let's write down the common uses of these drugs. Okay, so we will name the use and we will select which is the better drug here, which is the better drug. Okay, one is your clonidine withdrawal. Clonidine withdrawal. Okay, so clonidine withdrawal, which is the better drug? Reversible is better than irreversible. Okay, better than irreversible. Okay, then you have cheese reaction also. Reversible drugs are better than irreversible blockers. Okay, then you have pheochromocytoma. Pheochromocytoma, the best drugs which can be used is irreversible blocker is the best drug which can be used. So that is the story of your alpha 1 and alpha 2 blocker. Then next one we have alpha 1 selective blocker. Alpha 1 selective blockers. So alpha 1 selective blocker. So we are speaking of alpha 1 selective blockers, my dear student. So alpha 1 selective blockers, what are the drugs we have? We have first one, alpha 1A blocker. Alpha 1A blocker. Okay. You have a drug called as tamsulosin. Tamsulosin. Okay. We have one more drug called as silodosin. 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 Okay. So silodosin, and also you have one more drug, tamsulosin. Alpha 1A blockers are used for the treatment of symptoms of BPH. सिम्टम्स ऑफ बीपीएच का सिम्टम्स ट्रीट करने के लिए अल्फा 1A ब्लॉकर, बिकॉज अल्फा 1A receptor specifically located in the urinary bladder sphincter. So if I block alpha 1A receptor, bladder sphincter will relax. Okay, that is alpha 1A blocker. Okay, so we have alpha 1A and alpha 1B blocker. Alpha 1A and alpha 1B blocker. So these are the drug of choice in the patient. Drug of choice in the patient with BPH and hypertension. BPH and hypertension. So the drugs includes your prazosin, okay, alfuzosin. Okay, then you have your next drug. What is that? That is your terazosin. So many zosin are there. All the zosins are your alpha 1A and alpha 1B blockers. Okay, so alpha 1A and 1B. Prazosin is a drug of choice for, so drug of choice for, yes, scorpion sting. Very good. Scorpion sting. Okay, it's also a drug of choice for scorpion sting. So that is the story of your alpha 1A blockers. Okay, there is no alpha 1B blocker, no FDA approved drug. We do have some chemical. Okay, alpha 2 blocker, alpha 2 blocker. It is not approved. It is not approved yet. Not approved yet. Okay, so you don't have to worry much about it. Okay, so the next one, the drug name is called as yohimbine. It is a plant derivative drugs. Okay, then let's go to the next group of drugs. What is the next group of drugs? The next group of drugs which we have are very, very important. That is your beta blocker. Beta blocker. So beta blocker, we have beta 1 and beta 2 blocker. Okay, beta 1 and beta 2 blocker. So beta 1 and beta 2 blocker, the main drug which you have is propranolol. Propranolol is a beta 1 and beta 2 blocker. Apart from propranolol, other drugs are timolol. Okay, you have your sotalol. Okay, all these drugs are your, what is that, beta 1 and beta 2 blockers. Okay, then here propranolol related, the questions are very, very important. Propranolol is the drug of choice for, in few conditions is there. So in those conditions are essential hypertension. Okay, it is useful in panic attacks. Okay, this propranolol also is useful in prophylaxis of migraine. Okay, so prophylaxis of migraine. Any other drugs which are used in the prophylaxis of migraine? So we have few of the important drugs. Okay, so other drugs includes your tricyclic antidepressants. Okay, and apart from that, ergots are useful. In the prophylaxis of migraine. Apart from these ergots and tricyclic antidepressants, okay, anti-epileptics are also useful. Okay, anti-epileptics such as valproate. Okay, still other drugs are there. Candancetran. Candansartan. Okay, Candansartan is also useful. Candansartan, it is a angiotensin receptor blocker. Yes, it is useful. Okay, so remember this. Other drugs are your TriCS, ergots, anti-epileptics, Candansartan. So many drugs are useful. Okay, so this is a story of your, what is that, prophylaxis of migraine. Okay, now propranolol is also useful in hyperthyroidism. Okay, so once we understood about this, beta 1 and beta 2 blocker, propranolol will cause some side effect. One is bronchoconstriction because of its beta 2 blocking property. Propranolol also causes bronchoconstriction as a side effect. So propranolol is contraindicated. Almost all the beta blockers are contraindicated in COPD and bronchial asthma. COPD and bronchial asthma. Understood? So propranolol is a contraindicated in COPD and bronchial asthma. Okay. Timolol is also sotalol also. Okay. So once we understood about the beta blockers, let's go to the next one. Beta 1 selective blocker. Beta 1 selective blocker. Beta 1 selective blockers. Okay. So beta 1 selective blockers, my dear students. Let's discuss about those drugs. What are the drugs we have? Please listen to me. So we have drugs such as acebutolol, okay, betoxolol, esmolol. Okay, so when you're looking at the esmolol, this is the shortest acting drug. This is a shortest acting drug. Okay, then we have celiprolol. Okay, then you have metoprolol. Okay, yeah, all the lols, atenolol. Okay, atenolol. Okay, so these are the drugs which we have. Okay, selective beta blockers. Okay, selective beta blockers useful where they're useful in the treatment of hypertension. Okay, they're useful in the treatment of tachycardia. They're useful in the treatment of tachycardia. Okay, they're also useful in the treatment of very very important, which you need to remember, chronic heart failure, but contraindicated in the acute heart failure. Acute heart failure, you are not supposed to give the beta blocker. If you give beta blocker in acute heart failure, patient can die because of the bradycardia. Because of what? Bradycardia. Okay, everybody able to follow? Yes or no? कुछ तो बताओ, हाँ या ना everyone? Okay, hypertension, tachycardia and chronic heart failure is in the chronic heart failure contraindicated in acute heart failure. Okay, these drugs are useful in glaucoma. So glaucoma के लिए best drug of choice usually first line is your timolol बच्चों, which is a drug of best used timolol. Okay, but if the patient has a history of asthma, COPD or smoking history, okay, because smokers also prone to prone to developing prone to developing a COPD. So that is why that time we are going to use, if that is the scenario, then we are going to use betoxolol. Which drug we are going to use? Betoxolol. Okay, so that is the story of your adreno blocker. Then we have alpha and beta blocker. Okay, what are the alpha and beta blocker we have? Yes, we have a drug called as carvedilol, and one more drug is there called as labetalol. Labetalol ka kahani I already told you. Labetalol is the safe in pregnancy. Okay, PIH, pregnancy induced hypertension. Okay, but this labetalol is contraindicated in pregnant female with the hypertension and as a history of asthma or COPD. Okay, this is a very important. Okay, so that is the story of your general pharma and autonomic nervous system. Because these two systems are very complicated and having a lot of information, I had to go through step by step. Okay, but from here on after, what we are going to do, so now for some time we are going to do one set of these things, drugs which cause some side effect, or okay, so common side effect of the drug versus what are the drugs which will cause. Let's do that. Okay, is that okay for everyone? Is that okay for everybody? So that list is very important, because everywhere in the notebooks you would have studied. So here it will cause reflex tachycardia, here it will cause reflex tachycardia. So that time you need to be careful. Okay. So first let's start off with the most important ones. The drugs which cause the gynecomastia. Okay. Side effect and the drug. Okay, so this is one important series which you need to know. Okay, and the next series, after this, what we are going to do, we are going to do the system wise. We are going to go system wise. Autonomic nervous system is done. So after that, we are going to go to the system wise and do the drugs. Then the drug of choice. Okay, that is the main target now. Okay, for everybody, is that okay? Please give me a response. Is it okay? All audio, video, everything is clear, able to understand me or not? My idea is very simple, guys. Now what we are going to do, side effect and the drug which causes, the general side effect which they will ask you. Okay, because they have a lot of general side effects which can be asked. Okay, that series we are going to do now. Okay, immediately after that, one series of that ones, the next step what we are going to do, we are going to go into the each system. Okay, we are going to go into the each system, why it is the drug of choice and why it is the correct answer, like why it is the correct answer and what are the other important key points. After that, we are going to go towards the toxicities, because this is how we can revise the pharmacology in a better fashion. Okay, is that okay for everybody? Hi Anna, kuch to batao. Many people are watching, but I'm getting only one or two responses here. Because I'm doing very fast, you're searching in the notes or what? I'll give you the PDF of this one also. Don't worry. So, gynecomastia causing drugs. The first and most important, digoxin. What is the name of the drug, sir? Digoxin. Okay. One more drug is there, isoniazid. Isoniazid. What is the drug is there? Isoniazid. Okay. Then the next one is spironolactone. Spironolactone. Okay. The next one is cimetidine. Cimetidine. Okay. Cimetidine. Okay. Then the next drug which you need to remember, my dear students, one is estrogen. One is your estrogen. Okay. Any other drugs which will cause, even your ketoconazole. Ketoconazole. Okay. Even your ketoconazole. Which drug? Ketoconazole. Okay. All right. So these are some important drugs which can lead to gynecomastia. Even testosterone, if used only and only in a young age group and for a long period in a high doses. High doses of testosterone for a long period can also lead to gynecomastia, but these are some drugs which can be mnemonic disco. So this can be mnemonic disco. Okay. So this is first important. Okay. Let's go to the next one. That is side effect OCP failure. OCP failure. OCP failure is caused by all the enzyme inducers. Enzyme inducers. Okay, enzyme inducer. So OCP failure by which anti-TB drug? By which anti-TB drug? Okay, so the answer will be your rifampicin. Answer will be your rifampicin. Okay, so the next important point which can be is let's go to the next one. That is your agranulocytosis. 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 Okay, agranulocytosis is one of the side effect which can be caused by few drugs which can be commonly asked is your propyl thiouracil. Propyl thiouracil. Okay, then the next one, apart from that, there is one more important one which you need to remember. That will be your very important drug. That is your clozapine. What is the name of the drug? Clozapine. Clozapine is an antipsychotic drug. It is also a drug of choice in, here only I'll tell you, resistant schizophrenia. Resistant schizophrenia. Resistant schizophrenia. Okay, so this is the story of your agranulocytosis causing drugs. Okay, then let's go to the next group of drugs. The drugs which are causing main like some of the important ones, which includes your gum hyperplasia. Gum hyper gum hyperplasia. The few of the commonly used drugs are your calcium channel blockers. Few of the commonly used drugs are your calcium channel blockers mainly. Okay, then apart from the calcium channel blockers, the other drugs which can cause, you need to remember, that will be your phenytoin. That will be your phenytoin. This is a previous year question. This is a previous year question. Okay, gum hyperplasia is a side effect caused by, yes, your phenytoin. Okay, then let's go to the next one. What is the next one? Okay, so let's go to the next side effect which can be commonly asked and which drug. So let's start off with the side effects of amiodarone. Side effects of amiodarone. Okay, side effects of amiodarone includes your pulmonary fibrosis. Pulmonary fibrosis. Okay, so this pulmonary fibrosis also caused by, also can also be seen with the, can also be seen with the your, yes, a drug busulfan. What is the name of the drug? Pulmonary fibrosis can also be seen with your busulfan. Okay, amiodarone can cause both hypo and hyperthyroidism. Both hypo and hyperthyroidism. Both are possible. Confuse mat hona. Both are possible. Okay, hypo and hyperthyroidism, because it releases large amounts of iodine. Because of that, both can occur. Okay, then the next important side effect associated with associated with amiodarone, it will also cause corneal precipitate. Corneal precipitate. Okay, what is that? Corneal precipitate. Okay, then the next important ones, what is that? That will be your, my dear students, a very very important one which you need to remember. That is your, like apart from this one, so that will also lead to peripheral neuropathy. Peripheral neuropathy. Peripheral neuropathy. Okay, so these are some side effects which can be caused by amiodarone. Okay, then the next ones, side effects as a extrapyramidal symptoms. Extrapyramidal symptoms are caused by which drugs? Extrapyramidal symptoms. Extrapyramidal symptoms are majorly caused by antipsychotics. Antipsychotics. Okay. Then the next ones are your metoclopramide. 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 Okay. So because extrapyramidal symptoms are due to blockade of the dopamine receptor. Due to what? Due to D2 blockade. D2 blockade in the brain. Okay. So these are your antipsychotics and metoclopramide. Okay. Then next one, so this antipsychotics, okay, so this antipsychotics and metoclopramide causes the this one. Antipsychotic also causes some side effect due to same, also cause other side effect due to what? Due to same thing, D2 blockade. D2 blockage. So, because of the D2 receptor blockage in the brain, they will also cause other side effects. Other side effects includes, my dear students, very importantly, yes, one of the important ones is your other side effects includes your, so they're going to lead to neuroleptic malignant syndrome. Neuroleptic malignant syndrome. Neuroleptic malignant syndrome. Neuroleptic malignant syndrome. Okay, then also they will also lead to increase of prolactin. Increase of prolactin. Okay, so increase of prolactin can also be seen with metoclopramide also. So metoclopramide can also cause EPS and also your elevated level of prolactin. Okay, then let's go to the next one, side effects of lithium. Side effects of lithium. Side effects of lithium. Okay, this is also commonly asked question. What are the side effects of lithium? What are the side effects of associated with lithium? The lithium associated side effect are your Epstein anomaly. Epstein anomaly. Okay, Epstein anomaly. Okay, then lithium will also causes nephrogenic diabetes insipidus. So nephrogenic diabetes into treatment of this condition, the nephrogenic diabetes, the nephrogenic diabetes caused by lithium, the drug of choice is amyloid. Amyloid. Okay, then Epstein anomaly, nephrogenic diabetes insipidus. Okay, then the next part which you need to focus here is it will also cause side effects such as hypothyroidism, hypothyroidism. Okay, then it can also lead to the side effects such as ECG changes. What is that? ECG changes. तो यहाँ पे confuse हो जाएगा आपको. You'll get confused. Only hypothyroidism is seen with the lithium. Okay, but both hypo and hyperthyroidism can be seen with the amide. Okay, so confused नहीं होना चाहिए. Okay, so hypothyroidism, then patient will also get ECG changes. So these are some important side effect, but last but not the least, that is your tremors. Patient can have tremors. So remember one key point here: lithium do not cause extrapyramidal symptom. Okay, because lithium is not about blockage of dopamine receptor. Lithium does not block the dopamine receptor, so because of that you don't get a extra pyramidal symptom. This is a very interesting and important information, because previously पूछा गया था. What was the question? All of the following are associated with the usage of lithium except में last answer was tardive dyskinesia. Tardive dyskinesia is a extrapyramidal symptom. Okay, so what is least associated with lithium? Extrapyramidal symptoms. Okay, so this is a story of your lithium. Okay, so once you understood about the lithium, so there are some important other side effects also which we can encounter, which I'll tell you now. Okay, so let's go to the next one. Okay, so antibiotic and the side effect. Antibiotic and the side effect. Common side effects. Okay. Antibiotic and commonly asked side effect. Commonly asked side effect. Okay. I'm trying to cover up as much as possible side effect which are more correlatable to the recently asked question. Okay, I'm not blindly bringing in the side effect here, which I can correlate more commonly to the recently asked MCQs. Okay, based on that only I'm building the content here. Okay, बाद में मेरा ऊपर मत चिल्लाना. I have this much of time, right? In this much of time I'm trying to give out as much as possible content. Okay, so यहाँ पे side effect एक session खत्म करते हैं. Then we will do system wise drug of choices. Okay, so when I'm teaching the drug of choices, I'm going to explain the mechanisms also. That will be easier for us. Okay, because I have been dumping the drugs a lot. It is going to confuse you people. That is why. Okay, so first and most important, gray baby syndrome. Gray baby syndrome. Okay, so what is this gray baby syndrome? Gray baby syndrome is caused by chloramphenicol. But chloramphenicol not clinically used. Chloramphenicol. Okay, so gray baby syndrome, and chloramphenicol can also cause aplastic anemia. Chloramphenicol also cause aplastic anemia. Okay, aplastic anemia. Okay, both are the side effects of this one only. Okay, then the next one, gray baby syndrome's clinical features of the gray baby syndrome. Baby will develop vomiting, gray color cyanosis, okay, then baby will have metabolic alkalosis. Okay, so that is your this one. Okay, then you have next one. Okay, so that is a pseudomembranous enterocolitis. Pseudomembranous enterocolitis, usually caused by cephalosporins. Okay, so what is that? Pseudomembranous enterocolitis, usually caused by cephalosporins. Okay, then let's go to the next one. That is your very important side effect which you need to always understand. That is your Harish-Herxheimer phenomenon. Harish-Herxheimer phenomenon. What is Harish-Herxheimer phenomenon? Harish-Herxheimer phenomenon is a allergic reaction seen during what? Allergic reaction seen in the treatment of syphilis, in the treatment of syphilis, if you are looking this Harish-Herxheimer phenomenon, it is an allergic reaction when using penicillins. Okay, so penicillin use करके, if you are using penicillin and if you are treating the syphilis, that time it's an allergic reaction which will develop. What will happen? Penicillin will go and kill the syphilis microorganism, that is your Treponema pallidum. So if the Treponema pallidum dies, all the bacterial content, the content which is present in the spirochete, that is your Treponema pallidum, will get leaked. Once it will get leaked, so it will lead to what? It will lead to the side effects of allergic reaction. Okay, so that is your Harish-Herxheimer phenomenon. Okay, so then the important aspects which we need to recall, are your, yes, remember your very important ototoxicity. Okay, so ototoxicity is a very important side effect. Okay, ototoxicity, and along with the ototoxicity, other important side effects which can be seen, with this ones. What is that? That is your, yes, very importantly, aminoglycosides such as gentamicin. Okay, so there can be muscle weakness. So that includes your, very important aminoglycosides. Okay, aminoglycosides. Okay, then let's go to the next one. That will be your Redman syndrome. Which syndrome? Redman syndrome. Redman syndrome is caused by which one? Vancomycin. Vancomycin is a side effect caused by the vancomycin causes the side effect called as Redman syndrome. Redman syndrome. Okay, so the next important side effect, so that will be your, yes, yellow teeth discoloration. And also, my dear students, if there is a skeletal defect. Okay, skeletal defect. These are the side effect caused by your tetracyclines. Okay, then the next important aspect, what is that? So what is that? Yellow teeth and tetracycline is done. Okay, so once we understood about these side effects, I'll tell you one more side effect called as the tendinitis. What is that? Tendinitis. Okay, so tendinitis will be caused by your which ones? Fluoroquinolones. Okay, fluoroquinolones. Examples are your ciprofloxacin, okay, ofloxacin, levofloxacin, okay. So levofloxacin is specific for the specifically used in respiratory tract infection. So ciprofloxacin is called as used in urinary tract infection. So a person was treated for the urinary tract infection symptoms, and patient develops a tendinitis, that is most commonly caused by ciprofloxacin, because it is used for the urinary fluoroquinolone. Okay, so these are few of the most important and commonly asked or previously asked antibiotic related questions and their side effects. Okay, once we are done with that, let's go to the next aspect. What is that? So some other toxicity and side effects, let's continue. Okay, so one is ototoxicity causing drug. Ototoxicity causing drugs, most commonly need to remember if your aminoglycosides, okay, and loop diuretics. So these are the most commonly ototoxicity causing drugs. What are the ototoxicity causing drugs? Loop diuretics and your aminoglycosides. Okay, then the next one, hepatotoxicity. We cannot tell, a lot of drugs are there which are hepatotoxic drugs. Okay, then the next other side effect associated ones. So we discussed about peripheral neuropathy. Done. Okay, now we have to understand about few other clinical features and a drug of choices, and we will continue our rapid revision continuation. Okay, let's start off with the next aspect. So we discussed about the side effects, so let's continue to the next one. So let's continue to the diuretics chapter. Okay, autonomic nervous system is done. We are continuing to the next chapter called as diuretics. So this was just a 10-15 minutes of diversion for your mind and also refreshment of the knowledge. Okay, all right. Loop diuretics. So diuretics, when we want to understand about the diuretics, the first group of diuretics, we have a loop diuretics. Okay, loop diuretics are the main important point you need to remember. Site of action, where do they act? They act on the ascending limb of loop of Henle. Loop of Henle. So what is the mechanism of action? In the ascending limb, what will be there? For the reabsorption of sodium, potassium and chloride, we had a pump called as a NCKK pump, which is also called as a 2-chloride sodium potassium pump. Okay, so which is also called as 2-chloride sodium potassium pump. Mechanism of action is it will cause the inhibition of this pump, so it will cause the loss of, so basically sodium was getting reabsorbed by this pump, so it will cause the loss of sodium, sorry, NC, not NCKK, NKCC, I'm really sorry, NKCC pump. Okay, so loss of sodium and water. It will also cause the loss of potassium, leading to hypokalemia. Okay, and also it will also cause the loss of chloride ions. Okay, so the next important loop diuretics. Loop diuretics uses, where do we use them? These are the drug of choice for pulmonary edema. So for the pulmonary edema, what is the drug of choice? Yes, that is only your loop diuretic. These are useful for the forced alkaline diuresis. Forced alkaline diuresis. Okay, drug of choice for pulmonary edema, forced alkaline diuresis. These are the drug of choice. Okay, then the next important where we can use, they can be used in hypertension, they can be used in hyperkalemia. So that is the story of your loop diuretic. That's it. Okay, so what is the next point we need to know? Side effect. So they will cause hypokalemia. So the clinical features of hypokalemia are very simple to remember. Either hypokalemia is there, either hyperkalemia is there. It will lead to arrhythmia. And also it will lead to what, my dear students? Yes, it will also lead to the next important, muscle weakness. Okay, then it will also lead to hyponatremia. Okay, it will also lead to hypochloremia. It will also cause ototoxicity. Okay, these are the common side effects. So hypokalemia can be caused by other drugs also. Other drugs which cause the hypokalemia are your mainly AC inhibitors. Okay, the next ones are your NSAIDs. Both of them can cause the hypokalemia. So 3 drugs, hypokalemia causing loops. Okay, and also your thiazide diuretics also. Next group of diuretics, thiazides. Okay, then the next ones which we need to discuss, my dear students, what do we have? Yes, that is your thiazide diuretics, location of action, site of action. Okay, and mechanism of action. Okay, the drugs what we have, and uses and side effects. Okay, so the site of action, is your distal convoluted tubule. Okay, mechanism of action, it will inhibit sodium and chloride pump. Okay, but it will also cause the loss of all 3 ions, loss of potassium, okay, chloride and also sodium. All 3 ions will be lost here also. Okay, so that is the second point which you need to remember. The drugs which we have are, my dear students, your hydrochlorothiazide, okay, then you have your chlorthalidone. 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 Okay. Then uses, where do we use them? These are the drug of choice for the hypertension management. These are the drug of choice for the hypertension management. They're useful in congestive cardiac failure. And also they are the drug of choice for idiopathic nephrogenic diabetes insipidus. Idiopathic nephrogenic diabetes insipidus. Side effects again you have to remember. So they will cause the loss of main three ions. You mandatorily should remember sodium, potassium, chloride. Along with that, they will also cause a hyperuricemia. Hyperuricemia. Okay, hyperuricemia because they can lead to gout. Okay, so other drugs which cause the similar side effect, other drugs with the same side effect, so other drug with the same side effects, let's understand very importantly. So other drugs with same side effect, main commonly used drugs. Okay, you need to remember this. Okay, what is the drug we have? Pyrazinamide. What is the drug we have? Pyrazinamide. So pyrazinamide will also cause hyperuricemia. Thiazides will also cause hyperuricemia. Okay. Then we have a potassium sparing diuretics. Potassium sparing diuretics. So potassium sparing diuretics, we have two types of drugs. One which block the aldosterone receptor, and one more which block the epithelial sodium channel. Epithelial sodium channel. Okay, so epithelial sodium channel block. So epithelial's aldosterone antagonist, we have spironolactone. All right. Then the next one we have eplerenone. Okay. So we have epithelial sodium channel blocker. We have a drug amiloride. Okay, and we have one more drug, triamterene. Okay, so these are the, so here we know the mechanism of action is already discussed. Okay, and we discussed about the names of the drugs, and where do we use this drug? Okay, both the drugs are useful in chronic heart failure. We can combine them with other diuretics. Okay, then the next important aspect, eplerenone is the drug of choice for, if eplerenone is the drug of choice for what? Yes, eplerenone is the drug of choice for Con's syndrome. For the Con's syndrome, what is the drug of choice? Eplerenone is the drug of choice, eplerenone. Okay, so this is the story of your potassium sparing diuretics. Potassium sparing diuretics, the side effects of the potassium sparing diuretics. Okay, so they will cause a hyperkalemia. And I'm really sorry, यहाँ पे please hypokalemia में AC inhibitor, please change it. By mistake I had told AC inhibitors and NSAIDs, they don't cause hypokalemia. NSAIDs and other drugs, NSAIDs and your, so hyperkalemia also seen with NSAIDs and AC inhibitors. Small mistake. Okay, also seen with AC inhibitors and your NSAIDs. Okay, that is hyperkalemia, not hypokalemia. So hyperkalemia. Okay. Then the next one we have, so what is the site of action, where they are working? Okay, they are working site of action, okay, they are working in, both of them are working in the collecting duct. Okay, then the next group of diuretics, what you have, my dear student, that is your osmotic diuretic. Okay, osmotic diuretics, you have a drug such as mannitol. Osmotic diuretics such as mannitol. Okay, and you have one more drug, glycerin. Okay, Okay, even isosorbide also osmotic diuretic only. Okay, so this mannitol and all, so their site of action, okay, their uses, okay, and the side effects. Okay, these are the important points. Okay, so what is the site of action? This drug will work throughout the nephron. This drug will work where? Throughout the nephron. Throughout the nephron. Where do we use these drugs, bacho? These drugs are drug of choice in cerebral edema. Okay, cerebral edema. Cerebral edema. And also these are the drug of choice in acute congestive glaucoma. Acute congestive glaucoma. Acute congestive glaucoma. Okay. Then the side effect, it will lead to pulmonary edema. See, pulmonary edema's drug of choice is which one? Loop diuretic. Okay. But pulmonary edema is a side effect of which diuretic? Osmotic diuretic. And these both are previously asked questions. Be very careful. Okay. So that is the story of your, what is that? Osmotic diuretic, mannitol, glycerin and isosulfide. Okay, then the next important aspect, what is the next important aspect? We have last one, that is only called as carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. Okay, so carbonic anhydrase inhibitor, again please remember the पूरा diuretics के इतना ही questions. Site, where is the drug of choice, where what is the mechanism of action? The site of action, where it works in the nephron, it works in the proximal convoluted tubule. Mechanism of action, so it will inhibit the carbonic anhydrase enzyme, because of that it will lead to loss of HCO3 minus and also sodium and water. Okay, what are the three substances which are being lost? Carbonic anhydrase inhibitors say, so that inhibits carbonic anhydrase, because of which it causes the loss of HCO3 minus sodium and water. HCO3 minus sodium and water. Okay, so this is the loss of HCO3 minus sodium and water. So the important concepts which you need to understand from here. Okay, so what is that? That is, it also inhibits the carbonic anhydrase enzyme. Carbonic anhydrase enzyme in the lungs. So because of that, it prevents the CO2 loss. Okay, prevent the CO2 loss. And next important point to be remembered, it causes prevents the CO2 loss. And also, my dear students, which you need to remember is very importantly, it is the prevent the CO2 loss. That is why drug of choice in mountain sickness. Drug of choice in mountain sickness. Okay, and also, my dear students, it inhibits the carbonic anhydrase enzyme in the eyes. Okay, so that is why these are used in glaucoma also. Okay, what are the drugs we have? Acetazolamide. What is the drug we have? Acetazolamide. Acetazolamide is the drug of choice for mountain sickness. Then carbonic anhydrase inhibitor. One more drug is there called as brinzolamide. What is that? Brinzolamide. So brinzolamide is useful in glaucoma. Okay. I hope everybody able to understand. I hope everybody understood the concept of diuretics. Okay. These are the important points. Okay. So still we have, guys, listen to me. Still we have actually a lot of syllabus left. Okay, still we want to do the rapid revision of your cardiovascular system, okay, endocrine system, okay, your blood and TB. These are the main systems left. Okay, and we are having a time of 1 to 1.5 hours. That is not going to be sufficient. I will do one thing. I will take up more time from my side and I will do a part 2 to this video. Okay, so we'll make it as a part 1 and we'll make a part 2 also for this video. That would be better. Okay, all right. Okay. So with this much being said, let's conclude it as a part 1 and part 2 will soon enough come. After part 2 we will do the test. Okay, sir? Is that okay for everybody? Hi Anna, kuch to bolo. Is that okay, dears? Everybody? Okay. So with that much being said, let's conclude today's class here. Okay. And see you people in the next time, part 2. Okay. Thank you so much. Bye, guys. And all of you, whoever is watching these videos, you are utilizing the videos, right? So it would be a great help to us faculties and our team also. It will be great motivation if you share the videos among your friends. Okay, whoever will find it is useful, please share them, let them learn from this. Okay.